Director, IMA CGP Sub-Faculty, Dr. Usha Shah, to begin the proceedings of the meeting. Thank you.
Thank you, Dr. Anil Awad. Good morning, everybody. I welcome you on behalf of Indian Medical Association, CGP Sub-Faculty, Mumbai branch. Today, we have got a multi-speciality CME. There are 7 speakers with a super specialization in their field, and they are going to update us with the latest trend and treatment and something new about the management of the severe asthma. Now, the first speaker is Dr. Rajesh Swarnakar. He is a pulmonologist. And to introduce the speaker, I call my assistant secretary, IMA CGP Mumbai. Sorry. Yeah, before we start the program, before we start the program, I called our president to welcome you and update the upcoming events of the IMA Mumbai branch. Sorry.
शुक्र है आपको याद आया. Thank you very much, madam. Okay, good morning, everybody. On behalf of IMA Mumbai branch, I take pleasure in welcoming you all to this CME program. Friends, a brief review of the upcoming events. So today is the 27th. 2 days later, we are going to have a very nice program on adult vaccination, which has been directed by the IMA headquarters. And for that, we have arranged a 3-speaker program. None other than Dr. Shashank Joshi is going to be our speaker on COVID vaccines. Then the adult vaccination will be tackled by Dr. Girish Radhaksha and Dr. Vijay Punjabi. Dr. Girish Radhaksha is the Vice President of IMA Mumbai branch. Dr. Vijay Punjabi is our veteran. He is a past IMA Vice President at headquarters and of course President of Indian Mumbai also. Doctor's Day is coming on 1st of July, as we are all aware. And to celebrate that event, we are going to have a program on 4th of July, Sunday, in which we shall be having a webinar CME, where we shall be hearing from stalwarts, and the most popular speaker on that day will be Dr. Zarir Udwadia. Along with him will be Dr. Dev Pelajani and Dr. Sunil Wani. We shall be felicitating, as you know, every year we felicitate doctors who are contributing in their own specialty as well as to the society in different capacities. So on that day, we have chosen 4 doctors. Dr. Zarir Udwadia will be the first person. Dr. Sunil Keswani, who is a plastic surgeon, a reconstructive surgeon. Dr. Arsul and Dr. Mangala Gomare, our own Mangala Gomare, who is working so hard with the BMC in trying to control the COVID pandemic. Besides that, we shall be having the HM Shah Lifetime Achievement Award, which will be given to Dr. Rajendra Trivedi, our very own again, the past president of IMA Mumbai branch, and he has worked in various capacities even at the state level. We shall be having a Safe Motherhood Week starting from 1st of July. For 1 week, there will be patient education and awareness programs on safe motherhood. There are going to be webinars which are going to be conducted by the headquarters. We shall be taking part in that, and we will be showing our own activity in that week. Next Sunday, that is 11th of July, we shall be having monsoon marathon. If conditions permit, we shall be getting together in a small number and celebrating the monsoon marathon. We may even have a blood donation drive that is still on the cards, 18th of July, Sunday, as well as a CME program on that very day. Friends, just a message. Yesterday, you must have heard and heard from the news that there was a big scam regarding the vaccination. I would just like to reiterate that IMA Mumbai branch and IMA, on behalf of IMA headquarters, I would like to say that we strongly condemn such acts performed and by such doctors, and we disown them. And it's a black day because such 1 or 2 people, they cause a very, very bad name to the whole community and the fraternity. So definitely we must outrightly tell them, outrightly condemn them, and we shall never want them to be in our community. So with these few words, I hand over the mic to Dr. Usha Shah. Thank you very much.
Thank you, President, sir. Now we'll start our program. The first speaker is Dr. Rajesh Swarnakar. He is a pulmonologist. And to introduce the speaker, I call my Assistant Secretary, IMA CGP, Mumbai Sub-Faculty, Dr. Kajal Ahuja.
Good morning, everyone. Dr. Rajesh Swarnakar. He is the Chief Consultant, Respiratory Critical Care and Sleep Medicine of Gatewell Hospital and Research Institute, Nagpur. After passing MBBS from Indira Gandhi Medical College, Nagpur, he completed postgraduate diploma in chest diseases from GMC, Nagpur. He then did DNB in respiratory conditions from AIIMS, New Delhi. He has been awarded the coveted fellowship of the prestigious American College of Chest Physicians and holds membership of American Thoracic Society and European Respiratory Society. He has been recognized as University and National Board Guide for postgraduate degree in respiratory medicine. He is the Secretary General of Indian Chest Society. He is the Director of Academy of Ethical Clinical Research Training. He has published, presented many research papers at national and international conferences. He is on the national editorial board of the leading national journal in the respiratory medicine, Lung India. He has worked as a principal investigator in many clinical research trials for many multinational pharmaceutical companies. Today, he'll be speaking on what's new in GINA 2021. Over to Dr. Rajesh Swarnakar.
Okay, thank you, ma'am. Can I share my screen? Good morning, friends, on this Sunday morning. And at the outset, I thank the organizer IMA Mumbai and Dr. Jitesh Mehta, the president of IMA Mumbai, having invited me for this enlightening CME on this Sunday morning.
Sir, our pleasure.
It is extended also from the Indian Chest Society, of which I am the secretary. So my task for the next 15 or 20 minutes is to enlighten the audience on treatment of bronchial asthma in these times and to tell them about the latest what GINA has given in its report in 2021. So let's find out what's new in GINA 2029.
Sir, your sound has gone.
Sir, please unmute yourself. Please unmute yourself.
I'm not audible?
Yes, sir. Yes.
Now you are audible.
Just a minute, there is some problem with my...
Yeah. Again, the voice is not coming.
Again, voice is gone. Please unmute yourself, sir. Please unmute yourself.
So am I audible now?
Yes, yes, sir. Yes.
Yes, so thank you for introduction and also very good morning for this enlightening CME that you invited. So what we are going to see in next about 15-20 minutes is that what is new in this GINA 2021, and of these deals about the management of asthma. So first of all, what is this actually global initiative for asthma is actually short term for GINA, and it was established by the WHO and also National Health of Lung and also Blood Institute in 1993. This was to increase awareness about asthma, to improve asthma prevention and also management through, of course, a coordinated worldwide effort. And of course, GINA is an independent actually body which is not influenced by any of what we call pharma company, and it has been only funded by its sales and also licensing of its reports and also figures. Hence, actually, GINA is actually it's not a guideline, but it is actually a report which is also global evidence-based strategy that can be adopted for also what we call local health systems and also medicine availability. And it earns by actually having its report sold, and it's popular in also many of the countries. It is quite practical focus, and also multiple flow charts and also tables are there, which is very, very helpful for also clinicians to see. And also the GINA strategy report is updated every year. And of course, this is unlike any of the guidelines. Guidelines take a longer time to get updated. They just get dated. They are formed in 1 year and they are not updated. But GINA report is updated twice a year, and we have all what latest in how to manage asthma. So after this, what are these key updates that are there in GINA 2021? Is how to manage this COVID, how to have the risk of SABA treatment. So there is a shift of treatment of mild asthma in the sense that we are not just using inhaler which has got standalone what we call salbutamol. So that the short-acting beta agonist is almost going out of actually management, and we'll see why. There is a track 1 and track 2 treatment for treating milder asthma. We have got actually newer thing what is called as actually management and maintenance and also relevant therapy in the same inhaler, and we have got what we call symptom based treatment. So what we are going to see in this update is these changes. And it's always people say that what about asthma and COVID-19? So each and every disease is being now related with, of course, COVID now. So a simple advice which is given by GINA is that you have to continue good asthma management, you have to maintain good, of course, symptom control, you have to just reduce actually the risk of severe exacerbation, and at the same time you have to just minimize of the need of this oral corticosteroids, because they will just further impinge the immunity. Inhaled corticosteroids are to be continued, so they have to take their prescribed asthma medication, and also particularly inhale also corticosteroids. And a written action plan has to be there, so you have to make sure that all patients have actually a written asthma action plan, because patients are fearing to come to hospital, and there are also frequent lockdowns, so they may not be able to reach the hospital actually so much so frequently as was in pre-pandemic. So they had to have a written action plan advising them to increase controller and also to reliever medication when asthma worsens. So there were always apprehensions, when of course COVID-19 started, and there were some reports which said that are people with asthma at increased risk of COVID to have actually severe COVID-19? Are people with asthma at increased risk of COVID-19 related deaths? And have there been more asthma exacerbation during the pandemic? And comforting enough, the answers to all this is no. So no, people with asthma are not at risk of getting severe COVID-19. People with asthma are not at increased risk of COVID-19 related deaths. And of course, there has been no asthma exacerbation seen actually because of the pandemic. In fact, on the contrary, we saw just a reduction in asthma exacerbation and influenza-related illness in this pandemic. So that is actually a comforting news. Hence, in COVID-19, advise patients to continue taking their prescribed asthma medication, particularly inhaled corticosteroids. Are ICS protective in COVID-19? You must have seen that AIMS the protocol says that you can, in about mild asthma cases, just from starting, you can have what called budesonide inhaler, actually 400 micrograms, 2 puffs BD for about 28 days. And this is actually a result of a STOIC study which was done in NHS UK, and our site was also one of that center to have just done this study. And there are news that this is I mean, quite effective therapy and people have got benefit. But of course, what we call final results are yet to come. But it has been included in the AIMS of protocol because of the STOIC study, what we call preliminary results, which were published in Nature Lancet. So as I said, make sure that all the patients have a written asthma action plan advising them to increase controller and reliever medication when asthma worsens, or take a short burst of oral corticosteroids when appropriate for severe asthma exacerbation. And avoid, of course, nebulizers where, of course, possible, because I mean, these are aerosol generating procedures, and it is equally good to know that even if nebulizer is not there, equally effective is pressure meter dose inhalers if we just delivered it through then also a device called also spacer, and of this can be used instead of actually nebulizer. And of course, you have to add what we call mouthpiece or mask to the spacer if it is required for better compliance. And as you know that diagnosis of asthma is based on actually spirometry, so you have to do spirometry, but in this pandemic, again, that is actually what we call an aerosol generating procedure, and hence should be avoided. So of course, follow aerosol droplet and also contact precautions if suppose spirometry is also needed. And also consider asking patients to also monitor this PF. So instead of asking them to come for also spirometry, you can have a peak expiratory flow device to be given them at home, and then they can just monitor and just tell them their also values, so that you can just monitor the asthma also through what we call video consultation. And if it is done, if suppose there is some aerosol of generating procedure that's to be done, then of nebulization, oxygen therapy, or sputum induction, all these things should be avoided. But if it is there, then you have to just follow the strict infection control that now we are very well versed in this COVID-19, of course, pandemic. There is another question that all asthma patients ask, that have COVID-19 vaccine been studied in people with asthma? So yes, in all basically vaccine studies, we had included asthma patients, and they just seem to be quite effective and safe in these population. So just to actually begin, what is personalized asthma management? Because this is very important in this pandemic. Patients are not able to reach out to doctors, and they have to manage on their own maybe sometimes. So, and also just what we can only meet on what we call video consultation. So you have to review their symptoms, see if they have got exacerbations, if they got side effects from this medicine. You have to assess their lung function and also see their patient satisfaction. You have to adjust the treatment of modifiable risk factors, and also then also morbidities. You have to adjust their pharmacological strategies, asthma medication, and asthma education and skill training regarding their devices. Now there are many devices which are there in asthma. As I said, there are also dry powder inhalers, meter dose inhalers. There are also spacers. So all these things has to be, actually someone has to train them on that. And of course, confirmation of diagnosis is of course necessary. Symptom control and modifiable risk factors. You have to address also their comorbidities, because they can have gastroesophageal reflux disease and also sinusitis. And as I said, that this inhaler technique has to be checked, and you should always have patient preferences. You cannot dish out them what you want, but you should ask them whether they are comfortable with inhaler with spacer, or they will be comfortable with what we call dry powder inhalers or some other such devices, and then what are their goals as such, and of this should match yours. And as you all know that there are just several diseases which can mimic this wheezing and also breathlessness, and hence it's very important to have a confirmed diagnosis of asthma. As I said, the gold standard is spirometry with also reversibility test after actually giving them four puff of SABA. So this is to be done, and if the patient is under control, you have to also revisit your diagnosis if you are
if it's really treating asthma or not. That is quite important before you think that this patient has got uncontrolled asthma. Now there is a shift of change in treatment of asthma. We had been using, that inhaler of salbutamol, and people have been hooked to that inhaler. People take that salbutamol inhaler on the go, and this is all available in the pharmacy. But it has been now shown that actually regular use of SABA, even for 1 to 2 weeks, is associated with adverse effects. So you don't basically use this, and now there is also discouragement in terms of this GINA report that says that we should discourage use of only SABA alone. That's of, so that of SABA stands for short-acting beta agonist, like inhalers like Asthalin. So they would go for beta receptor downregulation, decreased bronchoprotection, rebound hyperresponsiveness. Its use causes decreased bronchodilator response, increased allergic response, and increased eosinophilic airway inflammation. Because what happens is that asthma has got two of the aspects. One is, of course, what we call bronchoconstriction. Other is, and another very important, is inflammation, which is not taken care by this. So people ignore that inflammation. They would just go for bronchoconstriction reliever, and this can aggravate their asthma unless they are on some what called controller medication like inhaled corticosteroids. So higher, of course, use of SABA is associated with adverse clinical outcomes, and in fact it has been shown that if suppose a person is using more than 3 canister of Asthalin or some similar salbutamol inhaler, it is associated with higher risk of severe exacerbation because they are not taking care of inflammation. Only bronchoconstriction is being taken care of, and that flares up their inflammation and of causes problem. And those who are hooked to only these canisters, and those who are only using this salbutamol, which happens because it gives them quick relief. So of course they think that this is the primary treatment for asthma, which is not so. In fact, contrary to the belief, if a person using more and more of this actually inhalers, it is associated with much higher risk of dying from asthma. Hence, it has to be replaced with inhaler corticosteroids, which actually reduce the risk of asthma death. So you have to also do the risk cost reduction along with what we call addressing the bronchoconstriction. Hospitalization, exacerbation, of course, requiring oral corticosteroids. So all these things can be prevented if suppose a patient of asthma is also given inhaled corticosteroid as actually a controller medicine. And it is there because of SABA adherence is poor. They will only take this short-acting beta agonist inhaler, Asthalin inhaler, only when they have problems. So they are not sticking to that. And this can cause problems, which has been seen in several studies, and GINA has brought this fact very well in this report. So this mild asthma cases, as if suppose you have seen the earlier GINA report, it should say that you should take SOS or emergency use of the short-acting beta agonist. But now GINA is stressing that basically even that should be replaced by a low-dose ICS and also formoterol combination inhaler. So this budesonide has been studied of low dose budesonide and formoterol, and actually using ICS formoterol as a reliever reduces the risk of exacerbation compared with using a SABA reliever, with of course similar symptoms control and also similar lung function. And only alternatively, if you're not able to give this, then only you have to follow this track 2, which is an old approach of only giving SABA reliever, but you should consider whether the patient is likely to be adherent with a daily controller medication of inhaled corticosteroid. Otherwise, they'll be exposed to the risk of SABA only treatment. So this SABA only treatment is now going to go out of it. Maybe in the next, I think, report of GINA, we are going to see that this can be eliminated. I think together it's actually a transition phase. So the new GINA recommendation, if you see in all the steps of bronchial asthma, you have got a combination of ICS, what we call a low dose inhaled corticosteroids and formoterol, as of course a reliever, which is now the preferred approach. So even for emergency use, even for the rescue use, that blue inhaler which people used to keep should be replaced by a inhaler which has got a low dose ICS formoterol combination. And track 2 is an alternative which has been given in a transition phase, that with SABA as a reliever, if track is not possible, in some of the countries the combination inhalers may not be available. It is there in India, but in some countries it may not be available for now. And maybe after this GINA, after this thing, they will be able to of course give this, but as of now if it's not there, then if they can go to track 2 with a caveat that they should ensure that patient of asthma is also taking inhaled corticosteroids along with this SABA, this thing SOS use. So GINA track 1, which is now going to be preferred one, is why is this preferred for adults and adolescents? As I have told, because using low dose inhaled corticosteroids, formoterol as reliever reduces the risk of several exacerbation, because exacerbation is caused by inflammation, and of course bronchoconstriction is only its result. So only taking care of this bronchoconstriction is not at all going to solve your problem. So you have to also use a low dose inhaled corticosteroids to take care of inflammation, along with what we call formoterol, which will take care of what we call bronchoconstriction, so that patient will get the complete relief and will not go to exacerbation. So how it is to be used is, of course, when a patient at any treatment step has asthma symptoms, they use this low dose inhaled corticosteroids, which actually budesonide formoterol, in of course a single inhaler for symptom relief. So they take inhaled low dose corticosteroid as well, along with a bronchodilator, which will be a LABA or a long-acting beta agonist like as formoterol. And even in steps 3 to 5, patients also take ICS formoterol as a daily control treatment. So in fact, this is giving us a very good treatment modality in which a single inhaler has got both inhaled corticosteroids as well as a formoterol, which can be also used in also cases in which they have got problems like emergency use. So for together, this one inhaler can have maintenance and reliever therapy, and hence this therapy is called as MART therapy, or what we call maintenance. So it can also be used for maintenance, so it can be taken regularly, and then whenever there is a burst of some emergency, there is some also increase of prostate breathlessness, they can again take this extra dose of this same inhaler, which now they can keep for both as of maintenance as well as reliever therapy. So now, recommendation for maintenance and reliever therapy in step 3 to 5 is maintenance and reliever therapy in ICS formoterol. As you know that it also reduces the risk of severe exacerbation. So compared with regimes with SABA reliever, it has been shown that it also reduces the risk of severe exacerbation, and these are comparison studies which have been taken account by this GINA, which were available since last 4 or 5 years, and now they have taken a concrete decision that we've got enough evidence to really give away this standalone Asthalin or salbutamol inhaler. So this is maintenance and reliever therapy, which has been of course brought in step 4 and step 5 as well. So ICS of responsiveness varies, and some patients whose asthma is uncontrolled on this SMART therapy with low dose ICS formoterol despite good adherence. So you have to always check before you say that this is uncontrolled, to actually check the inhaler technique, because that is the most common problem, that you would dish out the inhalers oral spaces or DPI, but then a correct technique has to be ensured, and it should be checked on each and every visit. And of course, these patients, after checking this thing, if they were uncontrolled asthma, then they will of course benefit from increase the total daily maintenance dose to of course medium. So this low dose can be increased to medium dose, and we can have this maintenance and reliever therapy even in MART this thing, so that we can have a what we call medium to high dose of inhaled corticosteroids along with this formoterol, and a low dose of what we call corticosteroids and a formoterol, of course, whenever they have got problem in between. So this thing comes as a rescue, actually rescue inhalers for all the steps. This is what is a take home message actually for us. Even if you have used this medium dose inhaled corticosteroids, so after you have used this low dose inhaled corticosteroids, and then you have now used this medium and formoterol, and patient is not under control. Now here step 5 is there, in which GINA says that you can actually use long-acting muscarinic agent like also tiotropium bromide. So you can add this. So now you can give triple combination of drugs which contains a steroid, which contains a long-acting beta agonist, and which contains a muscarinic antagonist like tiotropium bromide. And there are also different steroids that can be used. There is no head-to-head trials of course between them, so anything is better as of now. So of course beclomethasone and formoterol, glycopyridine combination of fluticasone, furoate, vilanterol combination, or also momentous intercranial glaucorium. So each of these has got one, I think, steroid, inhaled corticosteroids, one LABA, and one, of course, what call LAMA, which is there. And it has been seen that of lung functions improves once you add this long-acting muscarinic agent like diaphylpromin to this medium or high dose ICS LABA, and it improves of lung function, but not symptoms. So in also severe exacerbation, in some studies, add-on of LAMA also modestly increases the time to severe exacerbation requiring oral corticosteroids. And for patients with exacerbation, it is important to ensure that the patient receives just sufficient inhaled corticosteroid, that is at least medium dose of ICS LABA, actually before considering them adding it to LAMA. So it is, so now in step 5, you can add three drugs in, of course, a combination of inhaler, which is even available in India. Another addition which has come in Gina, and Gina was talking about this but telling it as actually macrolides, but now there are specific studies only on azithromycin, and for these severe asthma patients who are not controlled by your medium to high dose inhaled corticosteroids and also what long-acting beta agonist, and even after using this LAMA or striatonide, you can now add azithromycin 3 days a week, which has been confirmed as an option for consideration after specialist referral. So one has to see that whether he really needs it. And it has been seen by just several reports that it also significantly reduces exacerbations in actually patient taking high dose ICS LABA. It also reduces exacerbations in patients with eosinophilic or even also non-eosinophilic asthma. And as before, but then there is a caveat of using azithromycin, that before considering add-on azithromycin, you should check the sputum for atypical mycobacteria. You should not have a patient in which you are using azithromycin only one drug, because these are the drugs to be also used in atypical mycobacteria, which is quite common in also countries. So you should just rule out that. You should check ECG for long QTc interval, and again recheck after a month of treatment with azithromycin, because some of them have this problem. And of course, there are some reports which say that if you use azithromycin for just more than about 6 months, it can cause antimicrobial resistance in a certain population. Another thing that has been given in GINA 2021 is that just don't stop after initially just also taking eosinophils, and blood eosinophils is an important investigation for choosing your biologicals, which are now available, and future of asthma therapy is now on biologicals and not on inhalers. In fact, there is a lot of increased interest in them. Initially they were not there, now they are there, a bit costly, so maybe we are still using, but and all these biologicals indications of treatment with them depends on blood eosinophils for eligibility for biologic treatment. So it is said that a recommendation is to repeat blood eosinophil if low at first assessment in a patient with severe asthma, which has been confirmed by a study that these patients initially have got low eosinophils, but then they can turn into a higher eosinophilic count, and thus will be quite benefited by taking biological treatment. So that what Gina says is that you just initially see these blood eosinophils. If it's not eligible, then again just see it after a month whether the eosinophil counts have increased, so that these cohorts of patient can take benefit of actually biologicals which are there. So just to summarize, my talk for GINA 2021, it has given for how to treat asthma and also COVID. It has given some also our vertical guidance in how to go about also managing asthma now, and a very shift in treatment for this SABA treatment. So you should not use standalone salbutamol. For step 5, for patients who are quite severe asthma, and we are going to have a talk on severe asthma later after my talk, there is an option, like if suppose a patient has been giving median to high dose of inhaled corticosteroids and formoterol and still has got asthma symptoms, don't just add oral corticosteroids or don't just make them dependent on OCS. Now we have got options of adding this LAMA or also referring them to phenotypic assessment because availability of this also various biological like anti-IgE, anti-IL-5, 5R and anti-IL-4R, which are all available in actually India. Like omalizumab was the first to be available, and then of course now we also got what we call benralizumab now, which has come, and it has opened an array of pathways for treatment for this patient. And this is a very important thing, that even if you are giving these high dose inhaled corticosteroids, this is also not acceptable, because there are also certain high risk associated by just using even high dose of inhaled corticosteroids. So before you go to actually using high dose of ICS formoterol, you should see that these are not given, and then he can have an option of adding to LAMA or azithromycin, or actually referring them for this phenotypic assessment. So that is all about this GINA 20 doctor. Thank you for your patient listening. I'm sorry I had some problem, and hence my this video was shut off to let my voice at least go. Thank you very much.
Thank you very much, Dr. Swarnakar. It was an excellent presentation in a very simple language. Sir, do you think, as per the revised guidelines, formoterol ICS is the single inhaler for asthma management?
Pardon?
As per the revised guidelines, do you feel that ICS and formoterol is a single inhaler in the asthma management?
Yes, so that is what we are coming to now. So we were actually contemplating this since quite a long period, but now we've got very firm evidence, and GINA has come up with this, that you should not use standalone because salbutamol and this low dose, but it should be low dose inhale corticosteroid, and this thing, which of course should be used instead of just using what they call a salbutamol inhaler. So salbutamol inhaler is now out of there, although it is there still, because in some of the countries we don't have availability of this combined inhaler, hence it is still there. But I think time has come to see the effects, because when you use this short acting beta agonist, you are only taking care of bronchospasm. But this inflammation part, which is in asthma, is not taken care of by that. And if suppose a person keeps on just using this because salbutamol inhaler, then he may have problem with exacerbation later. And as we said, there is an increased risk of death if he is just using too much of this inhalers, because it is available over the counter. It gives them very quicker relief rather than with inhaled corticosteroids, and they think that this is the primary treatment of asthma rather than anti-inflammatory inhaled corticosteroid.
Sir, what about using this combination in recent COVID management?
So I know that people are using this combination of formoterol budesonide, but as of now, as I told you, that STOIC study, which originated from actually NHS UK and which was published in Lancet, only talks about inhaled budesonide. So only budesonide has been used in an inhaled form, and formoterol, if suppose patient is asthmatic, even before COVID, then of course you can combine this formoterol and inhaled budesonide, but not for every patient, because as you see in the AIMS protocol, only I think inhaler budesonide, standalone budesonide has been used, and not the combination. But if patient has some pre-pandemic, he had asthma, then you can combine this for sure.
That's the question.
So there's one more question. What is the role of SABA in today's era?
So, as I said to you, it's being phased out. So it has been seen, as I was telling, that now role of SABA is almost going out, and GINA has taken a very bold step that you should not use SABA, but you should use low dose inhaled corticosteroids, because when patient is having a bit of exacerbation, when patient is having some emergency problem, it is the inflammation which has given rise to bronchoconstriction rather just bronchoconstriction happening. So if we use only just SABA alone, then that is not going to take care of it. Patient is going to exacerbate, patient is going to get admitted in ICU. And it has been seen that those who just keep on using only this inhaler as their treatment of asthma have got a poor outcome. So it's being phased out. So I think maybe in another GINA report, maybe 1 year or 2 years afterwards, we may think that this thing will be phased out. It has been kept still as a track too, because as I said, some of the countries don't have the combination, and then there will be problems. So that's why, because it is being this GINA report is adopted in various countries, and there are some poorer countries which do not have. But India is lucky to have all the options available as of now. Now, and then we also have got triple dose of combination single inhalers now.
I want to know regarding azithromycin.
Yeah, so azithromycin, so we were talking about macrolides that macrolides can be added. But now even in this macrolide, GINA has specified only azithromycin studies are there. So they cannot use any other macrolide, but azithromycin, which has got immunomodulatory effect and anti-inflammatory effect, it is not only being used in asthma, but it is being also used in COPD patients, severe COPD smoker patients. It has been also used in also bronchiectasis patient as an immunomodulator. So azithromycin has got a multiple role. As you know, it's also being used in cardiac patients in some conditions. So same way it has been studied in asthma, and it is to be given only when you have exhausted all the options of medium dose inhaled corticosteroids to be used with formoterol, and then also it's not having patients not able to afford the biological therapy, which still is quite costly. Then of course you can use azithromycin. It's to be, once it is used, it can be used in a dose of 250 to 500 milligram depending on weight. It can be used for 6 months, or initially you can use it for 1 to 2 months and see if suppose there is some improvement, and then you can use it for 6 months. But as I said, there are some caveats in
Yeah.
its use.
Sir, any role of aminophylline?
It is
So
too cold.
yeah, so I know all of us we have been using this drug since quite well, but low dose aminophylline can be used, and if you see, it is not their international guidelines, but if you see the Indian guidelines, which has been made by Indian Chest Society, we have got this drug as a low dose aminophylline in our step 5 treatment. So many of the countries take some cues from China but do not adopt it fully. So Indian Chess Society has seen this this thing, because they are quite afraid of using aminophylline. So they say there is also therapeutic or narrow index is there, but we are not finding our patient. We were using it since ages. So even I use low dose aminophylline as a step 5 treatment, because that is quite we got experience. We have not found any adverse effect which what Western literature reports, and comes handy. So yes, I do use in step 5 treatment once you have exhausted all the options of inhaled medicines, and it is there in the ICS guideline. So, but now we are talking of GINA only. So of course in GINA it doesn't have any role.
Dr. Awad, I think you can handle it,
Yeah,
Dr. Gupta.
Thank
yeah,
you.
yeah. Over to
Thank you
Dr.
very much.
Shashank. Yeah.
Thank you,
Thank you.
Dr. Rajesh. Wonderful talk.
Thank you.
Now the second speaker is Dr. Prashant Chajer. He is an interventional pulmonologist. And to introduce the speaker, I call Dr. Sarita Devi, who is a convener IMA CGP subfaculty. Dr. Sarita Devi.
Good morning,
Uh,
friends.
Dr. Shajat, can we
Doc-
have your introduction slide? You have shared the screen.
Oh, you want me to, sorry, shall I stop sharing?
Yeah, yeah, yeah.
Your introduction slide. Yeah. Should I start?
Yeah.
Yeah, you start.
Dr. Prashant Chajed is Director of the Institute of Pulmonology, Medical Research and Development, and Lung Care and Sleep Center, Fortis Hiranandani Hospital, and consultant at Lilavati and Nanavati Hospitals, Mumbai. After completing his undergraduate, he did diploma in environmental, TB, and respiratory diseases from College of Physicians and Surgeons, Mumbai, followed by MD as well as DNB in respiratory medicine. He was a fellow in the Department of Respiratory Medicine at the Royal Prince Alfred Hospital in Sydney, Australia. Subsequently, he continued as a fellow in thoracic medicine and lung transplantation at St. Vincent's Hospital, Sydney. He was further trained in pulmonary medicine at Chiba University Hospital, Japan, and University Hospital in Basel, Switzerland. Dr. Chajrid is a recognized expert in all facets of bronchoscopy and pleuroscopy with a keen interest in sleep apnea and transcutaneous carbon dioxide monitoring. He has also been an active clinical researcher in the area of interventional pulmonology, interstitial lung disease, obstructive airway disease, and lung transplantation. He has been an invited lecturer at numerous national and international meetings, and he is a well-recognized teacher and has been a faculty in numerous bronchoscopy and interventional workshops around the world. He has published more than 120 scientific publications in PubMed index journals. He has presented numerous abstracts of his research at national and international meetings and has received numerous awards for his research presentations. Today, he will speak on recent advances in severe asthma management. Welcome, Dr. Chajid.
Great. Thank you very much for this kind and elaborate introduction. And I would also like to thank the IMA for this honor and this opportunity to speak at this forum. So Dr. Rajesh Swarnakar has laid down the good background on the platform, I would say, in terms of the GINA management. Yeah, am I visible and audible?
Yes, sir.
Yeah. So Dr. Rajesh Swarnakar has set up a very good platform as far as the management of asthma is concerned. The new GINA guidelines are concerned, and he has also discussed about the approach that GINA uses as far as the management of asthma is concerned and what the recommendations are. He has also alluded to some of the advances as per the GINA guidelines are concerned, particularly which are used in as the step 1, 2, 3, 4, and 5 as you go up the step ladder. And what I am going to do is, talk to you about some recent advances in the management of severe asthma. And, this is a broad topic. And what I will do is I will just like to talk to you a little bit about the biologics and about bronchial thermoplasty. Dr. Rajesh Swarnakar alluded to the advances in the GINA, which the GINA mentions, and I will cover these 2 points. Now, as far as the biologics are also concerned, there are 3 biologics, and within this short period of time, it will be very difficult to cover all the biologics. And also, therefore, I will speak about the one that has been most recently approved for treatment in India. And I will also allude to the concept of bronchial thermoplasty, where a lot of data is emerging, and it is also useful in selected cases of severe asthma. So when we talk about severe uncontrolled asthma, we know that it is linked to poor outcomes and medical emergencies. In patients with uncontrolled asthma, 92% have normal or daily activities impacted more than equal to once a day, and 10 times higher risk of hospitalization. And therefore, there is an increased mortality in patients with severe uncontrolled asthma compared to those with severe controlled asthma. So therefore, having severe asthma is one, and then the second is the severe uncontrolled asthma. We also know that uncontrolled asthma accounts for a majority of the asthma cost, as has been shown in this particular figure here, and that uncontrolled asthma actually accounts for a majority of the cost involved in asthma care. Now, severe asthma has many different meanings. Asthma that is uncontrolled despite maximal optimized treatment and treatment of the contributory factors, or that worsens when high dose treatment is decreased. And relatively refractory to corticosteroids, rarely completely refractory. We know there are several patients who are well controlled with regular use of corticosteroids, and when you taper the corticosteroids, the asthma gets out of control. Therefore, severe asthma requires treatment with high dose ICS or a second controller for the previous year, or systemic corticosteroid use for 50% of the previous year to prevent it from becoming uncontrolled, or it remains uncontrolled despite this therapy. So as was highlighted in the previous talk, the GINA talks about inhalers, ICS LABA, then you can add tiotropium, then there is dose for montelukast, then you give all these 3 together. And once you have given all the ICS LABA, LAMA, and the montelukast, everything, and then despite that the asthma is not well controlled, then your typical approach is to use a oral corticosteroids. And as Dr. Swarnakar mentioned, that now in the years to come, that's where the change is going to happen. The change is probably moving towards biologics, or even maybe better role for thermoplasty. But all that depends on the evolving evidence, and the evolving evidence is working towards how oral corticosteroids can be avoided. So if you look at the severe asthma, it comprises of there are multiple phenotypes in the underlying, and these multiple phenotypes need to be addressed for the personalized treatment of the patient in a specialist care setting. And if you see here, you have the severe allergic phenotype, you have the severe eosinophilic phenotype, you have severe asthma with physiological impairment, and then you have a severe neutrophilic asthma here. And depending on this, which phenotype it is, the presentation for severe allergic will be rhinitis, seasonal exacerbations, allergen sensitization, high Ig levels. For eosinophilic, there is a presence of eosinophilic inflammation, and this may be present with atopy or without atopy. Then you have severe asthma with physiological impairment, where airway remodeling has occurred, there's smooth muscle hypertrophy has occurred, and there is a mucus hypersecretion. So this is the case where you could think about LABA, LAMA, and you can also think about bronchial thermoplasty, where the airway remodeling has also occurred. And then you have a severe neutrophilic asthma, where you can have a low grade of eosinophilic inflammation, and that's where one could use macrolides. And when you have severe allergic phenotype or the severe eosinophilic phenotype, that's when the monoclonal antibodies will find a better role. Now, eosinophilic has an impact in both allergic asthma as well as non-allergic asthma, and each of these can cause eosinophil activation, and this eosinophil activation leads to inflammation, and and therefore the inflammation is influencing the pro-inflammatory cytokines and the chemokines that impact airway tissues, and the non-immune effects, where eosinophil activates multiple cells, leading to narrowing of the airways and also mucus plug formation. So eosinophil, as the data is evolving, is also playing an important role as far as severe asthma is controlled. Now, it has been shown that the blood eosinophil levels are also related to asthma severity. There's a lot of discussion in India as far the role of helminths are concerned, parasitic infections are concerned. But when you control for all these factors, it has been shown that blood eosinophils are related as far as severe asthma is controlled, and in severe asthma is controlled. And if you see here, the cutoffs as far as the blood eosinophil levels in severe asthma, they are 150 upwards. And as you move above 300, there you have a adjusted relative risk, which is going more in favor of severe asthma as you cross 300 eosinophil levels. Again, also for acute respiratory events, also as you start to cross 300, 400, there's an increased risk of acute respiratory events. And overall, the acute overall asthma control reduces, if you see this third graph here, as the eosinophil levels increase, the overall asthma control is less. So the majority of patients with severe asthma have blood eosinophils more than 150, and the other clinical indicators include in this situations frequent exacerbations, low lung function, oral steroid responsiveness, and comorbid chronic rhinosinusitis with nasal polyps. And this is a very new hot area in the last few years about that is severe eosinophilic asthma, and we are going to discuss this as we go further down. Now, what are the other biologics that are also present and which are used in the treatment of asthma? There are three of them which have been approved. One is omalizumab. We have been aware of omalizumab for the last 8 to 10 years. It has been available in India, and it has been used for moderate to severe persistent asthma, and patients typically have positive, are positive for perennial aeroallergens. And we have been using this, it is IgE mediated, and we have been using the Ig levels and the history of atopy, etc., to select the patients having atopic severe asthma, and using the Ig level also to decide the dose of the monoclonal antibody, that's omalizumab. But that will not be the discussion. Omalizumab has been there for a long time. A few years ago, we had, now there are two monoclonal antibodies which are working on the eosinophil. One is mepolizumab and the other one is benralizumab. Now, mepolizumab is again an add-on treatment for severe asthma with the eosinophilic phenotype. And if you look at benralizumab, it's the same indication, add-on maintenance treatment for severe asthma in those who have the eosinophilic phenotype. Mepolizumab also we have heard over the last few years, and therefore today I will be discussing more about benralizumab. That is the new targeted therapy for severe asthma, and it is indicated as an add-on maintenance treatment for severe asthma with eosinophilic phenotype, and the dosage is now available in a prefilled syringe and is typically given every 8 weeks. Of course, you give the loading dose once every 4 weeks for the 3 doses, and then subsequently it is given every 8 weeks. Now, benralizumab, it binds directly to the IL-5 receptor. I have not gone into too much of discussion about the mechanisms and the pathogenesis, but the point is that there is eosinophil, which is responsible. It is used in eosinophilic asthma, and the IL-5 receptor is, the IL-5 itself is an important interleukin which is involved in severe asthma. And if you look at mepolizumab, there's an IL-5 inhibitor. And if you look at benralizumab, that is a IL-5 receptor inhibitor. So benralizumab binds directly to the IL-5 receptor on eosinophils. It recruits natural killer cells, and the natural killer cell depletes the eosinophil. And as you see here, that as soon as this medication is given, the eosinophil levels in the blood also goes down, and there's a 96% change from baseline airway mucosal submucosal eosinophils at day 84. So therefore, this monoclonal antibody causes a reduction in the peripheral blood eosinophilia as well as the tissue eosinophilia. And if you look at this, this is a more of a pictorial depiction of what I discussed in the previous slide. Now, there was this, Windward program, which was involving several trials as far as the evaluation of benralizumab was concerned. More than 10,000 patients have been studied worldwide, and there have been 6 phase 3 trials with 3,068 patients at 798 sites and in 26 countries. It's one of the large 3-phase development program as far as a biologic in respiratory medicine is concerned. Now, there are different, I want to just give you, I want to simplify this slide for the audience. When you look for these various 6 phase 3 studies, 2 of these studies, I would say the Kalima study and the Sirocco study, they looked at the efficacy of using this molecule in looking at the exacerbation. So some of the studies looked as an outcome to reduce the exacerbations of the patients having severe asthma, and of course looking at other parameters also in asthma control. And some of the other studies have focused also on the reduction of the oral corticosteroid use, because oral corticosteroids, we know some of our severe patients are taking 5 milligram, 10 milligram of oral corticosteroids almost on a regular basis or for most of the time in the year. And these were the important outcomes. And I would like you to just focus on these 2 things so that we don't get confused in this all data. Now, this was the phase 3 randomized double-blind placebo-controlled trial looking at the efficacy and safety of benralizumab in patients in adequately controlled medium to high dose, who are on medium to high dose ICS-LABA. That means they're taking a high dosage of ICS-LABA, and despite that, they are uncontrolled. And in these patients typically had a historical exacerbation the previous year. The asthma control questionnaire was also showing that there was not a good asthma control. FEV1 is less than 80%. The post-bronchodilator reversibility is more than 12%. And of course, they did not use any specific eosinophil cutoff. And these patients were randomized to benralizumab and placebo. And when you look at if you look at the baseline characteristics of placebo and all these arms, I just want to put across to you that all these baseline characteristics were very well matched. That means the placebo, the placebo arm, as well as the 2 benralizumab arms, all had a similar inclusion criteria, baseline characteristics as far as age, FEV1, asthma control, eosinophil counts, and number of exacerbations in the previous years were concerned. And the median eosinophil count was 370, and they had about 3 exacerbations in the previous year. Now, what we look at the annual exacerbation rate, AER, is annual exacerbation rate reduction was seen in patients with more than equal to 3 exacerbation in the past 12 months. And if you look at this trial one, Sirocco, it causes a reduction in 57% reduction in the annual exacerbation rate. And if you look at the other trial here, that also causes a reduction in 51% in the annual exacerbation rate. Now, so there are two things here. One is reduction in the annual exacerbation rate. That means you have a patient who's getting frequent exacerbations. That has come down. And the second point which I wanted to discuss with you was oral corticosteroid reduction. And in this particular trial, which is the Zonda trial, if you look at this trial here, again, the inclusion criteria is same. They wanted to see what is the median percentage change in the final oral corticosteroid dose compared with the baseline. And the secondary endpoint was, of course, annual exacerbation rate. So two important things that we would like to be controlled. And if you look here again, I think the placebo and as well as the trial arm were very well controlled. The mean exacerbations in the placebo was 2.5, and here in the Fasenra or the benralizumab was 3.1, and the median eosinophil counts in the placebo was 535, and in the benralizumab was 437. And what you could see in this particular trial is that the median percentage reduction from baseline in final oral corticosteroids while maintaining asthma control was looked at. And in 52% of the patients who were optimized to oral corticosteroid, that means before the patients were taken into randomization, the lowest minimum oral corticosteroid patients were brought to that dose, and in 52% of the patients you could eliminate the use of oral corticosteroids, and in the other patients you could reduce the dose of oral corticosteroids. So that's what one of the things. So when a patient comes to us, we want to say, the patient say, doc, how am I going to get benefit? We say, yes, you get less exacerbation, and the important thing is we want you to use less and less oral corticosteroids in your case. And now there are different case scenarios here. This is a patient with frequent exacerbations. Now what is this? I mean, this case scenario will allow us to place when to consider the use of biologics here. High dose ICS LABA and LAMA, as I said, format whatever it could be, ICS LABA formoterol budesonide or samrelfluticasone, and a LAMA could be glycopyrronium or tiotropium, and there's an increased use of rescue medication. Patient had 3 exacerbations last year. What is an exacerbation? Either you go to the hospital or you need an oral prednisone taper. That's what is an exacerbation. A comorbid chronic rhinosinusitis with nasal polyposis, and blood eosinophils were 410. And that was, if you see in these type of patients here, you can expect a reduction in 63% of the patients in 1 year. When you look at the data, will not have an exacerbation next year. And at the end of 2 years, 74% of patients will have no exacerbation. Now, when you look, so basically, as I said, you are looking, these patients in the case scenario, about 3 exacerbations per year, you can look at reduction in the number of exacerbations. Again, this is a clinical case discussion here. Patient is on oral corticosteroids of 10 milligram per day. 3 exacerbations are present. Blood eosinophils are more than 300. And again, that is where you would want to consider, aim would be to reduce the dose of oral corticosteroids. Now you have a situation where patients have a high IgE level and a high eosinophil level. Now, in the past, until recently, I would say, not past, recently, we have used a lot of omalizumab in patients with a high IgE level. Now the question comes, what happens to a patient with a high IgE level and a high eosinophil? And I think there's a lot of data to say that these medications such as even mepolizumab or benralizumab can be used in these patients to achieve a good control. So, if you have overlap, you could use one of the the IL-5 receptor antagonist. If you look at the annual exacerbation rate data by Ig level, if you rationalize it to IgE levels and eosinophil levels here, you clearly see that there is a 51% reduction in these patients as far as the acute annual exacerbation rate is concerned. So even in high IgE, high eosinophils, it helps you to reduce the exacerbation rate. And therefore, if you look at this again slide, I want to simplify it. This complicated slide says that and benralizumab reduces the annual exacerbation rates irrespective of the allergic state. That means you could have a situation where an individual has got a eosinophilic asthma, does not have a lot of allergies, but has eosinophilic asthma, and you have an individual with allergic component with eosinophilic asthma. In both of these situations, benralizumab reduces the dose of the annual exacerbation rate. There's improved breathing. Now, if you look at, this is a very important data where patients have been followed up to 40 to 56 weeks. And benralizumab is the anti-eosinophilic biologic, which has led to an improvement in lung function. We know that patients with severe asthma will have a reduction in lung function. And if you look at here from baseline, you have an improvement in 239 ml, then it moves to 43 ml at almost 305 days here. And as you go towards, as you go down further here, you see that in certain trials, it almost goes up to more than 350 ml. So these medications help to increase the dose of FEV1. I mean, what do we tell our patients with asthma? You don't want to have an exacerbation. We would like you not to be on oral corticosteroids. We would like you to have a good quality of life. You may be able to do all your regular activities. And we also want to improve your PFT values, that is the lung function value. And the important one is FEV1. As far as the safety is concerned, there is, a lot of data are concerned. There's a discussion if there is if you deplete all the eosinophils, will there be a problem? And there's a lot of data to show that depleting the eosinophils, which benralizumab does, is not so far associated with any problems as far as increased risk of infections, helminthic infections, parasitic infections, or even any malignancy concern as far as the data are concerned. Because eosinophils are present, eosinophilic inflammation can be present in all these organs: GI tract, blood vessels, nasal mucosa, liver, heart, lung, nerve, skin, etc. Again, my data, I will just go ahead. So therefore, just to tell you about benralizumab, the safety profile has been in line with the placebo so far. There's a good tolerance of, there's a good safety and tolerance data of benralizumab. And this is a paper that was published last year, April. Now, what we have seen is benralizumab leads to an early and a sustained reduction of eosinophils compared to mepolizumab and prednisolone. This is a paper that comes out, which has come up. I mean, the point in eosinophilic asthma is to reduce the eosinophils. Some of the biologics will reduce the eosinophils to a lower level. Some biologics will completely eradicate the eosinophils. And here we see here that benralizumab is more potent than the other biologic as well as prednisolone as far as in the reduction of eosinophils are concerned. When you look at the real world data at 1 year, there have been a 72% reduction as far as the exacerbations are concerned. And you see here that the asthma control questionnaire also improves. The mean asthma quality of life questionnaire shows improvement, and the FEV1 also shows improvement. Now, I've already discussed this dosing with you. So the key summary points as far as benralizumab is concerned are: eosinophilic airway inflammation is central to exacerbation of pathogenesis and poor symptom asthma control. Targeting eosinophil inflammation with benralizumab reduces exacerbation, improves asthma control, and maintenance OCS use is reduced in severe eosinophilic asthma. And these biologics are really playing an important role here. Benralizumab works both for atopic as well as non-atopic eosinophilic asthma. Now, quickly, a few words about bronchial thermoplasty. It's a non-pharmacological intervention for the treatment of severe asthma. It reduces excessive airway smooth muscle here. And, the idea is if you reduce this excessive smooth muscle here, which is highlighted here, you can reduce the bronchoconstriction. And if you reduce the bronchoconstriction, it reduces asthma exacerbations and also the severity of an increased response to an allergen or exacerbation, and it improves quality of life. So what this bronchial thermoplasty does is it reduces the smooth muscle, airway smooth muscle. This procedure is done using flexible bronchoscopy. And if you look at this particular expandable wires, these are used to ablate, cause a radio frequency ablation of the airway smooth muscle. And this procedure is done using this LR radio frequency controller. the mechanism of action here is that it works on the matrix deposition of the air, reduces the airway smooth muscle mass, and it also reduces the inflammation in severe persistent asthma. Now, you've got Dr. Swarnakar took you through all the GINA guidelines here. It is a step 5 here. When you've used all the maximum dose of your inhalers, Montelukast, some might use low dose, low dose theophylline. And then when the discussion comes about using azithromycin or using biologics or thermoplasty, that's when you, or oral corticosteroids, that's when you need to phenotype and find out what is the most suitable technique that could be used to reduce the risk of inflammation in these, or to improve the asthma control in these patients, avoiding the use of oral corticosteroids. So if we go through this entire GINA assessment, where does bronchial thermoplasty fit in? And that's the question you can ask me. There are two types of inflammation, two types of severe asthma. I can say you have the one which with the type 2 features, that is the inflammatory, and you have the second one with the non-type 2 features. The type 2 features would be the ones who are oral corticosteroid responsive or who are responsive also to the monoclonal antibodies. So that's, if you have a type 2 patient, then you go in the direction of monoclonal antibodies. If you have a non-type 2 patient, that's when you come to thermoplasty. Okay, and I already discussed with you where patients have a lot of physiological changes, airway smooth muscle remodeling, etc. If we have a patient who has been given a monoclonal antibody and the patient has not responded, that patient can also qualify for bronchial thermoplasty. So these are the two things that I would like to put across here. And as far as the data, quickly, there are multiple trials here. I don't want to take you through these trials here. There have been randomized control trials and sham trials. What a sham trial means, you do the entire procedure of thermoplasty, but you do not deliver the radio frequency ablation. So there's a very high quality trial data which is available here. And what do these studies say? There's an improvement in the clinical outcomes. That means, again, reduction in the severe exacerbations, 84% reduction in emergency room visits, and 66% less days lost from work. And these improvements are sustained for 5 years. And recently, there's a paper which has been published, which gives you a 10-year benefit data. Unfortunately, I could not prepare the slides for that, but you have a 10-year data as well. As far as bronchial thermoplasty is concerned, it causes a reduction in severe exacerbations, reduction in visits to the ER or to your emergency visit to your doctor, and that's extremely important. And it also causes a reduction in the hospitalization. So that's where bronchial thermoplasty comes. Typically done it is done over 3 sittings, done at 3-week interval. You do the right lower lobe first, you do the left lower lobe in the second visit, and in the third visit you do both the upper lobes. And thermoplasty has been quite safe. Several procedures have been done all across the world, and no unanticipated device-related adverse events or death. It is an acceptable safety profile. Some patients may have an increased symptom for a week, which respond well to steroids, and there's no increased risk of hospitalization, asthma symptoms, or respiratory symptoms over the next 5 years. And as I said, thermoplasty is good to reduce the asthma attacks, few ER visits, and few absence from work. And that's my last slide. I really want to thank you very much for your attention and also for the opportunity to speak with you.
Dr. Anil. Am I audible, Dr. Anil Awad?
Yes.
Dr. Anil Awad, please.
So you need to unmute. Dr. Awad, you need to unmute.
Anil, unmute yourself.
Okay, yeah, sorry. So there are a few questions. Are blood eosinophil surrogate marker? Are blood eosinophil surrogate marker for sputum eosinophils?
Yes, I think, there are a lot of data which have shown a good correlation as far as sputum eosinophils are concerned. So yes, a lot of the trials are now using blood eosinophils as a very good marker as far as the diagnosis of eosinophilic asthma is concerned,
Okay.
because
Thank you.
it has been very difficult to do sputum eosinophils. To check sputum eosinophils, you need a special lab, special techniques. And despite, there was a lot of research that happened over the last 20 years as far as the sputum eosinophils were concerned, but it was very, very difficult to transfer the technology into to a laboratory where physicians could use it on a very regular basis with a lot of ease. And that's how the data came up, looking at blood eosinophils as surrogate markers. And yes, blood eosinophils are actually now become important criteria as far as the diagnosis of eosinophilic asthma is concerned. And blood eosinophils have also been used to stratify patients. And accordingly, after you use these monoclonal antibodies for the eosinophilic asthma, there have been clearly improvement as far as the outcomes is concerned. Of course, these antibodies have also shown a reduction in blood eosinophils, which happen very fast. And subsequently, data have shown that after several weeks, there is also a reduction in tissue eosinophil when the tissue biopsies are done.
Thank you. What should be the eosinophil count to start IL-5R therapy?
So I think the data has been shown that you could consider at at more than 150 also, but typically in practice we are often using a cutoff of 300, and a sustained cutoff of the 300 is very useful. Sometimes when patients have received a burst of steroid, it might make sense to repeat the eosinophil count after 3 weeks, because sometimes receiving a high dose of steroid can also cause a reduction in the blood eosinophil.
Okay, thank you. There are two more questions with me. How long do we need to take biologics before deciding on whether it's working or not?
Yeah, so typically, what we have been doing is, over the last decade, we've used a lot of omalizumab, and the typical approach has been that you would use omalizumab for a period of four months, and you would look for assessment. That's how we would counsel our patients. So we see how the patient is tolerating. Is there a symptomatic improvement? And at the end of 4 months, we would decide whether the individual is responding or not responding, and then decide if those who were responders, we would go ahead and continue the biologics, and at 4 months, if we feel that yes, not, we would stop it. Now, as far as these eosinophil medications are concerned, again, similarly, we should look for 4 to 6 months, look at the response, and then take it forward.
Okay. Sir, what are the FEV1 improvement with biologics?
So as I showed in the slide also, the main, actually the outcome data, what are the outcomes that we're looking at? Are we looking at the improvement of FEV1? No, that's not the primary data, but there has been all these sub-analysis which have been done. The main thing that we are looking at is, reduction in the exacerbations, reduction in the oral corticosteroid use, improvement in quality of life. These are the most important parameters. Look, and as you have seen that there are some data which have shown, particularly with benralizumab, there is an increase in the FEV1 also when you do the lung function on a regular basis. One important point I really want to highlight here, as I want to take a chance to highlight here, is the use of spirometry. Often we have been promoting spirometry for last 2 or 3 decades in the diagnosis, by at some point get it done, do the diagnosis. Yeah, but now it has become an extremely important tool also to support as far as the outcome management is concerned. So in clinical practice, I'm talking about practice here now. In practice, we want to see how the patient is doing, how the patient's symptoms are. Patient should have no symptoms the day. He should sleep well, be able to do even sports if they want to do sports. They should not have any exacerbations. And then the important thing we now do is regular lung function tests whenever it is feasible. Maybe initially when a patient comes to you, maybe a couple of times a year, and then we encourage patients to have a lung function at least on a regular basis, once a year or once in 2 years, depending on the situation, so that you can actually also track the FEV1.
Okay.
And I mean, particularly because, in India, there's a lot of poor perception of as far as the asthma control is concerned. Yeah.
Okay. So there's one question which was asked long back. Is there any correlation between a prolonged treatment of asthma and mucormycosis in COVID?
No, I think that there is, to the best of my knowledge, there is no link to the prolonged treatment of asthma and mucormycosis. I think because I think the question stems up from the from the fact that again, inhalers are also ICS, inhaled corticosteroid. So a lot of the patients are looking at the corticosteroid, and I mean, fair enough. There's so much of noise on social media that they come up with these questions, and therefore we actually it helps me to also tell patients that it's an opportunity to discuss the role of inhaled corticosteroids in those who have come to me early for the early diagnosis or the new diagnosis. Because as you are aware, this is not the point of discussion, but we know there's a very strong data as far as budesonide is concerned in the treatment of early COVID. So it allows, there's no relation between, to the best of my knowledge, between inhaled corticosteroids and mucor. On the other hand, beneficial data as far as the initiation in the early part of COVID is concerned.
Sir, what is the proven effect of BT on AQ-LQ score?
So now, as far as the bronchial thermoplasty is concerned, recently there's a 10-year follow-up data also which has been published. I could not present that. And what is bronchial thermoplasty looking at? Let me simplify it further. What are we looking at as far as the advanced therapies are concerned in the treatment of asthma? Again, as I said, I'll keep on saying, reduction in exacerbations. You don't want to have an oral corticosteroid use. You want to have a minimal, you don't want to have any hospital visits, and you want to have an improved quality of life. So all these data, all these newer techniques, maybe monoclonal antibodies are concerned, or maybe thermoplasty and something new that comes today. All these techniques or therapies will have to look at these aspects, will have to fulfill these components to become acceptable in the treatment of severe asthma, and therefore bronchial thermoplasty also leads to an increased improved quality of life by sheer reduction in exacerbations, and of course reduction in the use of oral corticosteroids, and of course improved and not needing to go to the hospital, and also there's a lot of symptomatic improvement in these patients.
Thank you, sir. It was an excellent presentation. Over to you, Dr. Usha Shah.
Yeah, thank you, Dr.
Thank you very much for this opportunity. Agam, hello.
Yeah.
Now the next speaker is Dr. Agam Bora. He is a chest physician. And to introduce the speaker, I call President-elect Dr. Anil Hawar to introduce. Dr. Anil.
Yes.
Yeah.
Yeah. Good morning, friends. Dr. Agam Bora is a chest physician and medical director of Advanced Multi-Speciality Hospital, Vile Parle, Mumbai. He is also in charge of Vora Clinic at Borivali, West Mumbai. He is an honorary consultant chest physician at Karuna Hospital, Manav Kalyan Kendra, and Suchak Hospital. He is an assistant honorary chest physician and in charge of the Department of Chest and TB at R.N. Cooper Municipal General Hospital. He is also visiting honorary physician at Shivri Group of Hospitals. He is a graduate from Grand Medical College, Mumbai, and postgraduate in the field of pulmonology from LTMMC, Mumbai. He is an accredited teacher in chest and TB with MUHS and also a teaching faculty for FCPS and TDD at the College of Physician and Surgeon, Mumbai. He was conferred Young Scientist Award by the Tuberculosis Association of India. He has been recipient of various fellowships like Fellowship of American College of Chest Physicians, Fellowship of Association of Physicians of India, and Fellowship of National College of Chest Physicians, India. He is a very popular speaker and has delivered more than 500 guest lectures at various national and international fora. He is the assistant editor of Journal of Association of Physicians of India, that is the JAPI, and member of editorial board of Chest Indian edition. Today, Dr. Agam Bora will be talking to us on case-based discussion on severe asthma management. Over to Dr. Agam Bora.
Good morning, everybody. Thank you, Anil Bhai, for those nice words of introduction. And it's always pleasure to be on IMA platform. I owe lots to IMA I am very close to IMA in various levels. I must also express my sincere thanks to the entire managing committee. I got chance to speak to Jitesh Bhai yesterday, Dr. Girish Lad, Dr. Usha Shah, and of course those 500 plus doctors who chose to be here on this Sunday morning. I understand we're going to have a multi-specialty program, and there's a talk on thyroid nodule, there is a talk on malignancy, breast cancers, etc. And then we have had two interesting talks on asthma already. First was my another close friend Rajesh. He spoke on the updates of GINA 2021, and my friend, philosopher and guide Prashant spoke on recent advances in the severe asthma management. And my job now is to talk about case-based discussion on this severe asthma patient. And I'm going to talk about when to choose biologic, how to choose biologic, because that's what Prashant said is the advancement. The life was very easy when I was a student. Asthma was all bronchospasm, and all you do was treat this with tablet salbutamol, treat it with tablet phosphodiesterase inhibitors, those aminophylline. And when they have exacerbation, intermittently you would use short courses of steroid. We all believed spasm plays main role. And then came the concept of inflammation. From acute disease, it became chronic disease. From only spasm, it became only inflammation. From SOS therapy, or moving on to the continuous therapy. And now it's time to put patients on regular inhaled steroids. We are again moving from the guideline-based therapy to personalized therapy. We have realized that patients who do not do well, it's a time to phenotype them, understand their disease in detail, and offer them which may be best suited for him. And that is what is the concept of personalized treatment. Allow me to present a case. It is a hypothetical case of middle, say 60 years old women living with a husband and two children, has body mass index high, 36 years, obesity, referred to severe asthma clinic from local hospital for assessment following recent hospitalization. She has a history of asthma which is there since adulthood. She did not have it in her childhood. There is no family history of asthma. There is no family history of allergy. She has left her job due to frequent exacerbation. So over the last 20 years, she began getting these symptoms at the age of 40, and she's currently 59. So 20 years, she had frequent exacerbation, and it disturbed her to the extent that she had to quit her job. She takes high doses of prednisolone, somewhere around 50 to 30 milligrams a day, to keep her symptoms under control. I'm sure we don't see this kind of patients often. Most of your patients are responsive to steroid therapy. Most of your patients do very well when you give them the inhaled steroid. In majority of the situation, issues with compliance. Your patients don't like to take treatment, but if they take the treatment properly, I'm sure most of the disease remain under control. But then there is a small proportion that Rajesh showed in his slide, Dr. Swarnakar showed in his slide. A small proportion of patients are real tough to treat asthma, and this patient is one such case of difficult to treat asthma, which was labeled as severe asthma over time. So this patient required high dose of inhaled corticosteroids, and beta agonist as maintenance therapy, would require frequent SABA as reliever therapy. She was also put on leukotriene receptor antagonist. She was also treated with azithromycin. Prashant said in his updates that there are options where you may treat patients with azithromycin. This patient definitely had poor asthma control. You look at the symptoms are multiple times a day. Every time you ask her, she reports these symptoms as severe symptoms. It affects her daily routine. It affects her quality of life. The symptoms are present all throughout the year without much of seasonal variation, and she requires that short-acting, that is salbutamol inhaler, multiple times a day. Her asthma-related quality is poor. She has regular exacerbation. She has to visit emergency department every month, hospitalized 3 times at least in last 2 years. Luckily, no ICU admissions so far. She left her teaching job for 2 years due to increased number of exacerbation. In comorbidity, she had recurrent pneumonias, bronchitis, recurrent sinusitis, no surgeries done. She also had associated GID, was treated with PPI, also had type 2 diabetes and required medications for that. Investigations didn't really reveal much. Her X-ray chest was normal. The Ig levels were 50. eosinophil counts 320%. Did mention that 300 is generally taken as cutoff. Eosinophil sputum were high. FeNO you see is 80. For all those who are aware of FeNO is exhaled nitric oxide level testing. It's a simple clinic test. You make patient blow into it and you get the levels. Up to 25 is generally taken as normal in adults, and she had FeNO of 18. X-ray sinuses were normal. She was subjected to lung function test, and FEV1 was 69% predicted. So she had an obstructive pattern with mild reduction in lung function. So she did not have very severe obstruction so far as spirometry is concerned, but yes, she had frequent exacerbation and her quality of life was severely affected. So what's the diagnosis for Lakshmi? Lakshmi is clearly having adult onset severe asthma with frequent exacerbations and raised eosinophils. She also has obesity, she has type 2 diabetes, she has recurrent sinusitis, she has GID, and what is not mentioned here, it would definitely lead to a lot of stress and she would have associated panic disorders. The treatment would include the management of comorbidities. That means you would want to manage diabetes, you would want to manage obesity, you would refer to specialists for the associated treatment. And when it comes to asthma management, you would put them on treatment for asthma. Sorry. Yes. And then when this kind of patient come to you in this specialist clinic, your job is to first confirm the diagnosis, check the compliance, do phenotyping, optimize oral corticosteroid dose, and then consider newer therapies. How will you confirm diagnosis? It was shown by Dr. Swarnakar that yes, there are a lot of mimics of asthma, and many a times what you feel is asthma may not be asthma at all, or it may be asthma COPD overlap, or it may be clear case of COPD, or you may have missed that patient has something called as asthma plus. This patient may have associated allergic rhinitis, GERD, they may have associated psychosomatic disorders, they may have associated sleep apnea, and if you don't address these issues, patient may not have optimal improvement. So it is either not asthma or it is asthma with associated comorbidities. And if you've looked at that, if you've looked at compliance, probably you're talking about real severe asthma. So you have a symptoms of shortness of breath, cough, wheezing, and childish, and which is not controlled by your good therapy. You're either talking about look at this symptom in an asthmatic due to other cause, or it may be a non-asthmatic case at all. So you may have a GRD, anxiety, COPD, heart failure, bronchiectasis, vocal cord dysfunctions, etc., etc. And if you really come across that, you may need a variety of investigations. You may need a variety of investigation and specialist opinion to prove or disprove those things. If you feel that this is definitely due to asthma, you have done lung function, you've looked at FEV1 by FVC, or FEV1 by FVC is low, your FEV1 is into mild, moderate, and severe category, you give them inhaled beta agonist, and then after 20 minutes, when you rip the spirometer, it shows improvement. Yes, you know that you're talking about asthma. And then you look at adherence and inhaler technique. Once you're convinced that yes, patient is taking the inhalers properly and his techniques are right and his adherence to this treatment is proper, you have two issues. One, it could be due to high inflammation or it could be due to obstruction. You do spirometry and you do other tests like FeNO and eosinophilia, and you know that this patient has a severe obstruction or this patient has severe inflammation, and this is the chunk of patient, they are real severe asthma patients. And if this is normal, which is not going to be the case at that stage, but still if it is normal, you're not talking about asthma, you're talking about associated comorbidities. And these are the patients, as we discussed earlier, are the cases of severe asthma. So what is severe asthma? Severe asthma had many different meanings earlier, but now we believe that severe asthma is the asthma which remains uncontrolled despite maximally optimized therapy and treatment of all contributory factors once you have addressed the compliance and technique issues well. And the asthma which worsens when this high intensity treatment is withdrawn. So the minute you try to step down, there is probably increase in symptoms and it is relatively refractory to corticosteroids. So severe asthma requires that this patient is on high dose inhaled corticosteroid and requires second controller. It is on systemic corticosteroid for 50% of the time, or it remains uncontrolled despite whatever therapy you have observed. So this lady was definitely a case of severe asthma. And then there is a cluster heading which depends on FEV1. So you look at, once you confirm the diagnosis of asthma, look at FEV1. If FEV1 is more than 68% or less than 68%, look at maximal FEV1 that you achieve more than 65, less than 65, and here maximal FEV1 of more than 108. And looking at age of the patient, you can clusterize them into 5 clusters. So you have mild, moderate, or severe allergic asthma. You have other cluster where it is a fixed airway obstruction, and then you have a cluster where it is severe late onset asthma. So here we have done that, and now it's time to do phenotyping. For phenotyping, you have various markers. We have pheno, we have Ig levels available, you have sputum eosinophils available, and then there are certain other exhaled parameters available, certain other urine metabolites available. Most of us look at serum Ig levels, blood eosinophilia, sputum eosinophilia, and pheno. So if you have IgE in the range of up to 150, you take it by and large normal. More than 150 would be considered a topic state, and these are the IgE mediated asthmatics. Your blood eosinophils, various studies take different levels of eosinophils, 150 to 300, but it is not a single value. This patient remains with you for a time, and by the time you decide about personalizing therapy, you know that any level of high eosinophilia, and if eosinophil is the culprit, I don't really go by the absolute value of eosinophil. It is the eosinophilic asthma which would require a personalized therapy. Sputum eosinophils, more than 2% is high, and pheno, if you have a high pheno, 25 to 50 is taken as intermediate, and more than 50 is taken as high pheno. After doing this phenotyping, you would probably look at steroids. You have, and the question that you would ask is, you have the patient on high dose corticosteroid. Is it working for this patient? Do you want to change the management approach? And when it comes to steroids, I remember that second year Stratoscar figure where you have a huge pot belly, a short stature, a buffalo hump, a cataract in the eyes, sugars fluctuating, fractures there, a vascular necrosis, a paper money skin, and the list of side effects. So you have a short-term side effect, you have a long-term side effect, you have an effect on glucose metabolism, you have appetite changes, fluid retention, weight gain, hypertension, peptic ulcer, mood changes, aseptic necrosis, and you have a long-term like adrenal axis suppression, growth retardation, skin thinning, hypertension, diabetes, Cushing's, cataract, muscle weakness, impaired function, and whatnot. And trust me, more than 93% of the patients with severe asthma will have at least one oral corticosteroid related adverse effect, because these patients are on oral corticosteroid for more than 50% of time in the previous years. Not only the regular steroids. Imagine if you have to use this burst steroid. Most of us have the habit of giving them a low dose, short course therapy. Say you have a patient who comes to you with exacerbation. I'm sure everybody here would treat them with Visalon 5 milligrams morning or evening for 5 to 7 days, called as short courses, short oral corticosteroid burst therapy. And if you have given 4 such courses in a year, this is also associated with specific adverse effects like osteoporosis, hypertension, obesity, diabetes, cataract, GI, and fractures. Imagine a short courses of just 4 every year could put them at a risk of getting it, and this happens. Many patients do not keep a record of their treatment plan. They keep on changing their family doctors and would be exposed to this steroid, putting them at higher risk of developing side effects. And then makes me probably come down to the last part of the presentation is biologic. So this patient is definitely a severe asthmatic elderly lady, a phenotype which probably would require a biologic, and you have 3 biologics available. We have omalizumab, we have mepolizumab, and benalizumab. Omalizumab is approved for moderate to severe persistent asthma uncontrolled by inhaled corticosteroid for more than 12 years with perennial aeroallergen sensitivity. Mepoli and benralizumab are recommended as add-on therapy for severe asthma in age group of 18 and above with eosinophilic phenotype. And there are hardly any side effects for this particular therapies. These are all humanized monoclonal antibody therapy. Look at these 2 options. So you have mepolizumab and benralizumab, which can be used for this patient. And Prashant did show about benalizumab, but let me give you a comparison of, since both these molecules could be used for this patient. There are studies available which talks about use of this molecule as a steroid sparing molecule, and you could see in the last column that Benali led to 75% reduction from baseline in the oral corticosteroid sparing, whereas Mepoli also had almost 50% reduction. That means both the drugs could help you in reducing oral corticosteroid. Benali has some advantage over mepolizumab, where there was 75% reduction compared to 50% reduction. And you could see that Prashant did show about Zonda slide. It talks about 52% of this patient with original dose of 12.5 completely eliminated steroids. In the sense, anybody who requiring 12.5 and less steroids on this therapy did not require steroids at all. 18% of the patients who were on 12.5, again, complete elimination of steroid in mepolizumab group. So this was mepolizumab group. There was benalizumab group. So that definitely Benali group had more number of patients who could be withdrawn from oral steroids. Annual exacerbation rate, again, both the trial, you have two studies, one with Benali and one with Mepoli. It talks about 51% relative risk of reduction in Benali group, whereas 48% relative risk of reduction when it comes to Mepoli. And this is the chart. You can see that various studies which are done with Benali, and this is the add-on study which was done, and it showed that there were no exacerbation in the second year of treatment. That means all those patients who were given treatment for more than 1 year, the second year onwards, they had fantastic reduction in that inflammatory inflammation, airway inflammation, and did not have a single exacerbation. This is the mepolizumab study, and somebody asked Prashant a question whether it leads to any improvement in lung function, and this is the study which shows that yes, benalizumab, if used, does show improvement in lung function over time. So I would summarize my case by saying that this lady was an adult onset severe non-atopic eosinophilic asthma with frequent exacerbation. She had variety of comorbidities. She had diabetes, she had hypertension, she had obesity. She also had a underlying psychiatric disorder. She was prednisolone responsive. The diagnosis was confirmed by phenotyping. She was evaluated, and her compliance to treatment and adherence was checked. She could elaborate a proper inhalation technique. All her comorbidities were addressed, and asthma mimicking disorders were all excluded. This patient was given the option of anti-eosinophilic therapy. As I said, we have two treatment available. One is anti-IL-5 mepolizumab and anti-IL-5R, that is benalizumab receptor antagonist, and this patient was put on benalizumab. The advantage of Benali over Mepoli would be, you need less frequent dosages, and hence it is a patient-friendly dosages. The quick onset of action. The onset begins as soon as 24 hours. There's near complete depletion of eosinophils. Even if you do the tracheal mucosal biopsies and look at eosinophil levels, they are completely wiped of eosinophils. And there is some data which says that there is better reduction in oral corticosteroid dosages. There is better improvement in lung function. Keeping those factors in mind, this patient was put on benalizumab, and she is doing well. I would end by a couple of slides which say that biologic agent should not be used reflex because there is failure of other agent. That means your patient does not do well. Don't have a reflex of putting them on biologic. It should be limited only in selected patient with a specific phenotype. And you have to confirm the diagnosis of asthma. For all that you know, for years, you may have missed the diagnosis of asthma. It may be asthma COPD overlap, or it may be asthma plus, as I said, there may be certain comorbidities which may have overlooked. And it is always wiser to revisit your patient, you reevaluate your patient, you reassess your patients, and run those investigations again. They may have associated psychiatric comorbidities which is not paid enough attention, and looking at those factors may bring about rewarding results. After years of use, your patient may not still be taking inhaler properly, may not still be compliant with treatment. Once you address all this, then only the label of severe asthma is given. And severe asthma is a retrospective definition. In the sense, a patient comes to you for the first time, please be no hurry to give label a diagnosis of severe asthma. I would conclude by saying that identifying the right patient for therapy-resistant asthma is well defined. We have realized what kind of patient would respond, what kind of patient to call it as difficult asthma, what kind of patient to label them as severe asthma. There are predictors of response of severe asthma to biologics. Yes, you have various biomarkers available, though there is some overlap, but you know that you can very well understand this by looking at IgE levels, their FeNO levels, their sputum eosinophil levels, and their blood eosinophil levels. Choice of right biologic for the right patients. You have enough indicators available. You have 3 biologics available, and by the end of next 1.5 years, you may have 2 more available. So you'll have a choice of biologics. Next 1.5 years is going to be very interesting. We're going to be learning more and more about biologics and its use in disease like asthma. Monitoring the response on biological, again, there are combined tool available. One must use biologics if chosen for at least 4 months. After 4 months, you reevaluate this patient, look at their eosinophils, look at their FeNO, and most important is look at their steroid, oral steroid dose reduction and the quality of life, the functional improvement, and assessing the treatment response. There is still some gray zone, but I'm sure we would learn that soon. This was the paper I published in JAPI last year, and it was on the asthma perspective in India, and I concluded by saying severe asthma is the condition which would require individualized approach. Phenotyping is the key to diagnosis and managing severe asthma. Major phenotype is early onset allergic asthma, but you do get patients with late onset allergic asthma. Biologics available in India were omalizumab and mepolizumab that time, and now we have Benali also available, and you would choose the right kind of biologic depending on the phenotype that patient has. Thank you very much for your patient here.
Thank you very much, Dr. Agamora. It is always nice to listen to you. And as you said, we have been to IMA many times before also.
I feel very much at home when I'm on IMA platform.
Yes. Thanks a lot, sir. Sir, there are a few questions. I'll just take one by one. What should be the preferred choice of biologics in case of overlap phenotypes?
That's a very good question. In situation where you have overlap phenotype, I think Prashant did show in the presentation, there are 2 drugs available. So you have a mepolizumab and you have benalizumab, and the way I chose in this patient, Benali may have some advantages over mepoli in terms of more number of patients could be put off steroids. There could be symptomatic improvement, and there is a dose convenience. In the sense, you need relatively less number of dosages when you are talking about benalizumab, because after the initial induction, you have to give it once in 2 months, vis-a-vis mepolizumab, which comes once in a month, and hence total number of doses may be less, and that would have cost benefit as well. Thank you.
Okay. So what should be the IgE cutoff to start omalizumab?
That's a nice question. Now, by and large, I don't believe at one particular Ig value, because by the time patients come to you, and by the time you label them as severe asthma, and by the time you decide about giving them biologic, this patient is with you for some time. Also, this patient would have visited a couple of doctors before visiting you, because we have the system in India or in Mumbai for that matter, that patient have free access to any doctor of their choice. And then by the time they come to you, you have multiple readings with you. Please refrain from relying on one value. You various labs have different techniques of doing Igs. So for me, it is important that patient has atopic status, patient's Ig values are high, and I have addressed all other situations for me to label him as atopic allergic severe asthma, and for me to consider biologics. There are biologics like omalizumab is studied for a particular range, and hence if you have Ig levels which are beyond that range, in that case we don't have enough studies, but I do use biologics in those situations as well. Thank you.
Okay. Sir, should we give antihelminthic before, like in country like India,
yes.
tropical countries?
Oh yes, for sure. And trust me, this anti-helminth would be given to these patients at various occasions before they come to you. every family physician has a habit of deworming patients, and I'm sure IMA has done excellent work of propagating this knowledge across the country, and all our family doctors are looking after those basic needs for patients, and we are regularly deworming those patients. And hence when they come to me or when they go to specialist, it becomes by and large not kind of required issue. Second thing is, I'm seeing this patient over 6 months. Your worm issue cannot go on for months together like this, and hence when I'm thinking about giving biologics to this patient, I think I'm pretty much convinced about this because of allergic asthma.
What precautions to be taken in treating pregnant lady with bronchial asthma?
Interesting point. Pregnancy and asthma. I would suggest you treat asthma the way you would treat otherwise. We have not much of experience in using biologics in pregnancy, but steroids as required you can safely use. Try to, during pregnancy, some of patients are far more compliant, and hence compliance and rest of the issues are taken care of. If required, you may use nebulization therapy. So far as possible, try to use minimal dose of steroids, but if your disease demands it, I think I would treat asthma the way it is required in otherwise situation.
Sir, you started your lecture with salbutamol. So the question is, what is the role of salbutamol in today's treatment of bronchial asthma?
Salbutamol has a role in today's time to look after those intermittent exacerbations. In the sense, currently the guideline says, as Dr. Rajesh Swankar would have shown you, that there is now changing concepts. We were initially looking at asthma as only bronchospasm, and now we are looking at it as all inflammation. And hence, bronchodilator is no more regularly required, but you require anti-inflammatory drug. Then came the last year change in GINA. GINA looked at it very closely and realized that what was again spoken as track 1 treatment, it may be interesting to put patients on beta agonist and steroids together, and came the concept of combination therapy. And that is what we are doing now. We are using formoterol and budesonide combination, and we are supposed to put this therapy in these patients regularly. If this patient is on regular therapy with long-acting beta agonist like formoterol and a steroid like budesonide, that means he's on twice daily combination. If he gets intermittent exacerbations, you have an option of treating that with salbutamol inhaler. Again, to avoid two different inhalers, a lot of us believe that you could use the same formoterol budesonide additionally, because it has a beta agonist molecule which acts very quickly. I think you could do that. So salbutamol, I would reserve it only for SOS use. Second, I would keep it only in very mildly, very intermittently, asthmatic patient who gets only while traveling, or who gets only in particular season and remains for a short duration. Those can be managed with SOS salbutamol. Otherwise, not much role.
Thank you, sir. I'll just take one more question, and we'll end up the question answer session. Sir, how to descale the oral and inhaled steroid and introduce biological?
Okay, that's a very interesting question. You don't really de-escalate steroid when you select patient for biologic, because severe asthma, if you look at the definition, it says that whenever you reduce high intensity treatment, the asthma exacerbates. That is what is the definition of severe asthma. And hence, you don't de-escalate this patient, you continue patients on the same therapy, you add biologic. When you add biologic, over time, patients will have symptomatic improvement, and patient will have improvement in terms of markers if you have a habit of monitoring. I would continue same treatment for 3 months to 4 months. At the end of 4 months, you reevaluate and start reducing the therapy. So your severe asthmatic, in spite of being on this high intensity treatment, is suffering. But when you put them on this therapy, they have a symptomatic improvement, and they have objective improvement. Their lung function improve, as was shown earlier, and your eosinophil count start going down. And that is the time you start reducing steroids. So I don't do it for 4 months. After that, I start doing it.
Thank you very much, Dr. Agam Vora. It was a really interesting question answer session. Thanks a lot.
Thank you. Thank you very much. Thank you for giving
Thank
me
you,
the
sir.
opportunity to be here, and thank you, Anil Bhai, for moderating it so well. I believe I am given impression that you're going to be president-elect. Wish you all the best.
Thank you. Thank you, sir.
Thank you.
Dr.
Now
Thank
the
you,
Leticia.
next,
Jitesh bhai.
thank you, Dr. Anil. Now the next speaker is Dr. Anil De Cruz, who is a consulting oncologist. And to introduce the speaker, I request Dr. Kashyap Dakshini, who is an IMA CGP member. Over to Dr. Kashyap.
Good morning, friends. Dr. Anil De Cruz is Director, Oncology Services, Apollo Cancer Centers. He is a well-recognized global leader, clinician, researcher, and teacher in head and neck oncology. He has served as Director and Chief of the Department of Head and Neck Surgery at Tata Memorial Hospital, Mumbai, India. He is a recipient of honorary FRCS from the Royal College of Surgeons, London, for his outstanding work in the field of surgery. He has undergone special training for head and neck surgery at the Sloan Kettering Cancer Center, New York, laser surgery at Vanderbilt University, USA, and speech rehabilitation at Indianapolis, USA. Dr. De Cruz is the first Indian to hold the position of president-elect from 2018 to 2020 and president from 2020 to 2022 of the Union International for Cancer Control, Geneva, Switzerland, which is the largest cancer organization globally committed to the cause of cancer control. With more than 350 peer-reviewed publications and chapters to his name, Dr. De Cruz is on the editorial board of many reputed national and international journals. He has delivered more than 500 invited lectures and nearly 100 named lectures, keynotes, and orations, both nationally and internationally. He was also instrumental in the initiation of the first MCH super specialty course in head and neck oncology in India. Today, Dr. De Cruz will speak on thyroid nodules, distinguishing the good from the bad.
Dr. De Cruz,
Sir, unmute yourself.
please unmute yourself, Dr. De Cruz.
Mute. Okay. Am I heard now?
Yes, sir. Yes, yes.
Oh, sorry. Apologies. Anyway, thank you for a generous introduction. I was saying I was with you all on the 31st on World No Tobacco Day. It was a pleasure interacting with the entire IMA at that time. The response was phenomenal. Today is again delightful. I followed the 3 talks on asthma, and it was exciting to see such active engagement. So thank you for the leadership, Jatin, Anil, all of you all for giving me this opportunity to be here today. I'm going to speak to you all on thyroid nodules and its correlation to cancer. And you must be wondering, as a general physician or as a specialist in some other field, why this is important. And over the next couple of minutes, I will try to tell you that this is a point that is very, very relevant to all of us as doctors. And you don't have to be a thyroid specialist to be treating or knowing about thyroid nodules. I bring you greetings from the Apollo Hospital, my new home after I left the Tata Memorial Hospital. It's a little far from town, but it's a state-of-art JCI accredited hospital. I brought in 5 specialists with me from the Tata Memorial Hospital. So we are changing, we do sub-specialization, we have tumor boards, and offer our patients state-of-art care at an affordable price. Now, the first thing about thyroid and thyroid treatment, more than half the cases that I do are redo surgeries. That means someone has done something outside and then they come to me. And that's basically because of a lack of understanding of the biology of thyroid nodules and cancer. You must remember that thyroid disease, surgical thyroid disease, is indolent and does not kill in the vast majority of patients. So there is no rush to send your patients for urgent surgery. The expertise of the sonologist, the cytopathologist, and the surgeon are very important to help get the right treatment for your patients. Now let's look at thyroid nodules. 4 to 8% of general population have nodules on palpation. So if you're at the other station and you catch 100 people and feel their neck, anywhere between 4 to 8% will have nodules. This is actually Western data. In our country, it's higher. 10 to 12% will have goiters that are palpable. If you did a sonography on your patients for any other cause, up to 50% will have nodules. Therefore, it's very, very important to distinguish between good and bad nodules. You can't operate on 50% of people who have thyroid nodules. Our hospitals would be only doing thyroid surgery. So it's important to distinguish good from bad. At the same time, we must be aware that the incidence of thyroid cancers is increasing worldwide. But if you remember your MBBS days, autopsy, pathology, 50% of people above the age of 70 who die of other causes will have small foci of papillary thyroid cancer like prostate cancer. These are called laboratory cancers. So while the incidence is increasing, probably we are diagnosing more laboratory cancers because of better imaging. Therefore, we only need to treat some cancers and not all. Good cancers equal to minimal treatment or observation. Bad cancers need aggressive treatment, surgery, radio, iodine, and other things. And to drive the point home that we are diagnosing more because of better imaging, Korea had a national cancer screening program. For $400, they would scan for 5 cancers: breast, bronchus, bowel, stomach, and prostate. Someone in the ministry said, let people pay another $25 and we will scan the neck for any other condition. At once, the incidence of thyroid cancer jumped, and there was a New England Journal publication that screening is resulting in overdiagnosis. 1/4 of these patients had tumors less than 5 millimeters. Surgery resulted in 11% hypothyroidism and 2% vocal cord paralysis for probably laboratory cancers. And this is removed now from screening programs. So the important message for y'all is don't unnecessarily put a thyroid or an ultrasound probe on your patients who come for other conditions. And this probably is the trend worldwide. Another New England Journal publication from the WHO IR that looks after cancer epidemiology, nearly 470,000 women and 90,000 men have been overdiagnosed of thyroid cancers in 12 countries. USA, Italy, France, most severely affected. And so also it's increased in India. When I trained at Tata's, we used to do about 100 thyroid cancers in the year. When I left Tata's, it was over 1,000, 1,200 every year. So you can see that there has been a change in the incidence and diagnosis in our cancer as well. So how do we decide who is good, who is bad? If the nodule is less than a centimeter, don't worry. Only if it is more than a centimeter will you investigate your patients. Nodules less than a centimeter, only if they have high risk features, we will evaluate. And what are these high risk features? Extremes of age. Pediatric nodules, 50% are malignant, so you must investigate. Above the age of 45, when the person has undergone all hormonal changes, more common in females after menopause, rare to see a thyroid nodule. Prior radiation to the neck, high incidence of malignancy, you will investigate. If patients give you a family history of thyroid cancer, or they have any of these syndrome, Cowden's, familial polyposis coli, Carney's complex, Werner's, we would then evaluate the thyroid. And if the patient has worrisome features on sonography when they are undergoing this test. Now, many people ask for CT scan, PET scan, ultrasound for other reasons. In fact, in the last few months, I've operated on about 5 thyroids which were diagnosed as malignancy because the patient underwent a CT scan for COVID. And then the technician saw something at the root of the neck, thyroid. They took few cuts on top, and we were fortunate to diagnose these cancers. These are called incidentalomas. Patients come to you for some other problem. You image, ultrasound, PET, CT, MR, maybe a car injury, spine pain, spondylosis, and you then find a thyroid nodule which is impalpable. These usually are less than a centimeter. Now, if it's a sonography, thyroid nodules are very common. I told you 50%, chances of malignancy less than 5%. CT, MR, the incidence is about 16-20% to pick up thyroid nodules. Malignancy, again, 5 to 10%. A PET scan, and you can see here an acute bright spot in the thyroid. If it's diffuse, it's thyroiditis. High chance of being malignant, close to 30%. Usually a PET scan is done for other causes, and you can then correlate whether the other cause needs treatment or the thyroid needs treatment. Here's a CT scan of a patient who went into the rooms because of spondylosis and then referred to me because of a non-palpable nodule 1.5 centimeters in size. Thyroid nodules you work up by 3 simple tests: thyroid function test, FNAC, and a sonography. There's no role for thyroglobulin. There's no role for CT, MR, and PET scan. They're usually not done. There are some indications which I will tell you, but only 3 tests: TFT, FNAC, USG, and these depend on the expertise, the FNAC and the USG of the person doing the test. So when you do the thyroid function test, if the TSH is suppressed, that means your patient has thyrotoxicosis. They will go for a radionuclide isotope scan. You'll see a nodule like this, and then you decide what you want to do, whether you want to give radio ID and FNAC, but a low TSH scan. Anything else, a scan is not done. You will then do further investigations if the patient has a nodule more than a centimeter. The second test, ultrasound. Why? It is safe, it's non-invasive, it's cheap, it's easily available, but as I said, it is operator dependent. Someone may be excellent doing sonography on obstetrics. Someone may be great doing sonography of the abdomen and pelvis and prostate, but that person may not be tuned to doing thyroid. Thyroid, you need a high frequency ultrasound probe and expertise. It is operator dependent. You know the characteristics of the nodule, you know the characteristics of the rest of the thyroid. You can target a fine needle aspiration cytology. If we decide to observe the patients, we can follow up these patients. So sonography is the second test that we do, and your sonologist must give you a reports according to what is known as a TIRADS classification that looks at 5 functions: a solid nodule, a hypoechoic nodule, microlobulated with irregular margins, microcalcification, and taller than wide. If they give you a score, it goes from 1 to 6. Closer to 5 and 6, the probability of malignancy is high. So when you read a report, please see that your sonologist has written TIRADS. If they have not written TIRADS, either they've forgotten and you need to ask them to do it, or that sonologist doesn't do much thyroid reporting, and you probably need to have the scan done by someone more adept to sonography of the thyroid. I've put up a representative picture just so that you can remember one point. The most pathognomonic feature of a malignancy in a nodule is what I marked in red: microcalcifications. See these small microcalcifications marked in red. Remember, the smaller the calcification in thyroid or breast, the more lethal. The larger the calcification, the less lethal. So microcals are one of the most specific signs that it is malignant. So you need to do that. The nodule will be hypoechoic. You will have microlobulations, which you can see marked in green, and it's taller than wide. The third investigation is a fine needle aspiration cytology. It's cost effective, very low false negative, false positive rate, accuracy upwards of 95%, and decreases unnecessary surgery by 50%. And again, it is very, very operator dependent interpretation of the slides. Please send to good centers that do a lot of thyroid work. And again, the report should come in what we call the Bethesda system of thyroid cytopathology reporting. So we have the Thyroids for sonography, we have the Bethesda, and as you go down, again, this is from 1 to 6, as you go down towards 4, 5, and 6, more likely to be malignant. Always remember that the FNAC should be done ultrasound guided so that you get adequate material and you don't have to repeat these tests. So once we have the thyroid function, we have the clinical history, we have the sonography, and we have the FNAC. If it is Bethesda 6, Thyroid 6, the patient will go for surgery. But otherwise, we use a diagnostic triad: clinical, sonography, and FNAC. Extremes of age, male gender, usually 5 nodules are in females, 1 in male. Family history of cancer, prior radiotherapy, signs of extrathyroidal extension, fixed gland hoarseness, or the presence of lymph node. These patients are surgical patients and need to be treated. You can't observe. Sonography, thyroid's high score, 4C, 5, 6, again malignancy. And fine needle aspiration cytology, if it is again Bethesda 4, 5, and 6, these patients come for surgery. Other patients can be observed. So look at a diagnostic triad before you finally treat your patients. CT scan is only done if you suspect that it is invading the laryngotracheal framework. MRI rarely done for advanced. We do for esophageal and vessel involvement to see the carotid, to see the esophagus. It's better than the CT. And a PET scan is never done in differentiated thyroid cancers. It's only when it becomes undifferentiated, very advanced, when radioactive iodine is not taken up, or in a variant of thyroid cancers called medullary thyroid cancers, which is only 5% of all cancers. So by and large, it is sonography. And if you feel your thyroid is a little advanced, you will do a CT scan and nothing else. Now, in our country, we see people with multinodular goiter, as the lady seen on the left of your panel. Rarely we see this solitary nodule. Which is more dangerous for you in your practice? Which one needs to go to the specialist? Many ladies will come in with the multinodular goiter and say, Dr. Saab, I've had it for 10 years, 5 years. Do you get panicky or no? Looking at the incidence of malignancies in goiters, here is a meta-analysis that was published in Thyroid, which is a very reputed journal, in 2013. Looking at all databases at the incidence of cancer in multinodular versus a solitary nodule. As you can see, the incidence of cancer is less if you have a multinodular goiter. This is called a forest plot. These are all the publications that have been reviewed. You can see these little dots tell you the incidence towards multinodular goiter, which is on the left of the line of unity, telling us that the incidence is less in multinodular goiter. This is in iodine insufficient areas like in our country. So multinodular goiter chances of malignancy are less. So all goiters don't need surgery. As I said, 12% of our population will have goiters if there is no worrisome features on sonography, on FNAC, and it's a multinodular goiter. You don't have to operate 12% of our population. We will only operate if the goiter is large, it's multinodular, it's cosmetically a problem causing pressures. If it goes into the mediastinum, because those goiters are very difficult to monitor and can grow quietly and cause problems. If it is toxic in a pregnant lady where radioiodine is not indicated, and please always remember, if your patient is hypothyroid, it's a medical condition. Never subject a patient to surgery, even if there's a goiter with hypothyroid. It's usually thyroiditis. You give the patient L-troxine and the patient will settle. So large goiters, mediastinal goiters, toxic in pregnancy, and of course, if there is malignancy on the FNAC and sonography, but if it's benign, it's only the three indications that I put. And what is cosmesis? Usually greater than 5 centimeters. But you could have a very thin lady where even a 2 centimeter nodule doesn't look good. In that case, we look whether it's a grade 3 goiter. And what's a grade 3 goiter or thyroid swelling? It is seen from a distance. So when the lady is with a flex neck or the patient is with a flex neck, if you can see the goiter, it is cosmetically disfiguring. The lady goes to the party, everybody asks, kya ho gaya gale mein सूजन आई hai. So those are cosmetically disfiguring. So size-wise more than 5, otherwise those goiters can be seen from a distance with the necks flexed. Don't give all your patients L-troxine for benign goiter. Here again is a meta-analysis. You give L-troxine, you do see some response. You can again see the diamond on this meta-analysis forest plot is towards favors treatment. But you'll have to give 8 patients L-troxine for 1 to benefit. The moment you stop this treatment, the nodules will regrow. And remember, our ladies who get thyroid nodules are normally in their mid-age. Estrogens are falling. They're already getting osteoporosis. You give more of thyroxine unnecessarily, you have side effects on the CVS, tachycardia, and on the bone. You're pushing them to premature osteoporosis, and it really, the benefits outweigh, the harm outweighs the benefits. So we do not recommend giving L-troxine for benign disease. Quickly, a few slides on malignancy. So if these nodules are Bethesda 5-6, we need to operate them, Thyroids 5-6. Remember that thyroid cancer comes in many flavors. But the most important cancer is what we call WDTC, which is well-differentiated thyroid cancer, seen in the blue color in the pie chart, which causes 90% of thyroid cancers. And these are usually papillary, follicular variant of papillary, and Hurtl cell. Medullary thyroid cancers, 5 to 10% arise from the parafollicular C cells, usually associated with the MEN syndromes. And then you have the rare cancers like polydifferentiated, anaplastic, and lymphoma. But in the interest of time, in what is most common, we'll just focus on well-differentiated thyroid cancer. It's a surgical disease. All disease must be removed with minimizing the risk of disease recurrence and metastatic spread. And you must minimize treatment-related morbidity because the neck houses 2 important structures, intimately related to the thyroid, the recurrent laryngeal nerve that supplies the vocal cord, and the parathyroid that looks after the calcium of our body. And here are the two structures seen, and complications across all series can be up to 25%. So you'll have a patient who lives, you'll fix the vocal cord, or you'll cause parathyroid insufficiency, and the patient will have to take 14 tablets of calcium daily or live with a hoarse voice. The outcomes depend on the expertise of the surgeon. So I told you, expertise of the volume on cytopathology, sonography, and surgery. Here is a publication showing that if you do more than 30 thyroid cases a year, your chances of length of hospital stay, hospital charges, complications, everything is much less based on the surgeon and hospital volume. So you must choose very carefully and send patients to a person who has expertise. Now, these cancers are of two types. There's a low risk cancer where the recurrence rate is 2% and mortality rate 1%. And there's a high risk cancer with a recurrence rate of 40%, mortality rate of 45%. So we need to recognize good from bad. Good, you do low risk, do less. Bad, high risk, you need more aggressive treatment. And here in a snapshot, I'm trying to show you what is low risk. Less than 45, it's the only cancer which has age in the staging. Tumors less than a centimeter, if they intrathyroidal, differentiated, unifocal, no nodal or distant metastasis, these patients are adequate with a hemithyroid. Anything more than 45 towards 4 centimeters, gross extrathyroidal spread, aggressive variants, multifocal, nodal metastasis present, distant metastasis, aggressive treatment, total thyroid. For lesions between 1 and 4 centimeters, we look at a combination of factors that I have listed on this slide. So remember that all patients with thyroid need not have a total thyroid. Low risk, you can only do a hemithyroidectomy. Now, many people ask me, why should we do conventional surgery? Why can't you do robotic? Why can't you do transaxillary? Now, there are many approaches, transaxillary, periareolar, BABA, which is bilateral axillary breast, retroauricular, periauricular. Now, do these have a role? All these studies come from South Korea. And I told you in South Korea, they used to scan patients and they had very small nodules. So ladies refused to go for surgery. That's why most of the publications are from South Korea. But to put it in proper perspective, I've just given an evidence-based review from South Korea. Usually we do open thyroidectomy, OT. Robotic thyroidectomy is less favorable in terms of cost, time, oncological outcomes, the morbidity, quality of life, short-term recurrence, similar in both groups. So open thyroidectomy is still the standard of care. 95% of patients heal beautifully with no scar. Robotic thyroidectomy is in high volume centers with low volume cancers in patients who have a high expectation for cosmetic outcomes. You have a film actress, 1 centimeter thyroid cancer, doesn't want a scar even for a week, then we might probably do it transaxillary. But 95 to 99% of our patients otherwise still have an open thyroidectomy. Thyroid cancer is a favorable cancer, and even if it's locally advanced, invading the trachea, the esophagus, as seen in this slide, 5 to 15%, it's worth operating these patients. You still have up to 62% of patients living out, 2/3 of patients, which is better than most cancers, even when they have invaded a joining structure. And here is data that I presented when I was at the Tata Hospital. 60% of patients were disease-free at 5 years with a median follow-up of 64 months. So even if it's invading the trachea, don't write your patient off, and the patient needs to have surgery. So in conclusion, Thyroid nodules are common occurrence. Thyroid cancer incidence is increasing, yet all nodules don't have to be treated. There are only 3 investigations you need to do: thyroid function test, FNAC, fine needle aspiration cytology, and sonography. Surgery is the main modality of treatment. Incidentallomas are common, and PET incidentallomas are the only one which have a concern. And choose your surgeon wisely before your patient is referred, so that your patient has clean surgery, minimal complications, and can go home and live for a long time. 90 to 95% of cancer patients with thyroid go on beyond 20 years. So it's very important to choose your patient wisely. Thank you once again for the opportunity to be on this podium. I'll be delighted to have any questions, and these are my coordinates. If anybody needs to get in touch with me, I'd be very happy to answer questions offline as well.
Thank you, Dr. De Cruz. That was a wonderful talk. You have explained in a very, very nicely in detailed form how to investigate and how to approach the cancer nodule, thyroid nodule, sorry. There are some questions. One question is, should every patient of hyperthyroid be investigated for cancer?
So the incidence of hyperparathyroidism in cancer, so usually cancer is euthyroid. Less than 5% of hyperthyroid patients will have cancer. So I told you, you do a TSH. If it's suppressed, you'll do a thyroid scan. In the thyroid scan, usually the uptake will be diffuse. If there's a solitary nodule seen, that patient will have an FNAC. If there's no solitary nodule, which is a cold nodule, so 5 to 15% of cold nodules in the thyroid gland can be malignant. But the incidence of malignancy in thyrotoxicosis is very, very low. So here is how you will work out your patients. You will first go ahead and do a isotope scan. If you see a nodule, the patient will have an ultrasound. You look for the features that I explained, do a needle test, and then decide whether the patient needs to have surgery or not.
The second question is, if the FNAC is not so reliable for diagnosis of medullary cancer, then which is the best way to approach that patient?
So medullary thyroid cancer is fairly accurately diagnosed on FNAC, but the foolproof test that you would do is a serum calcitonin. So you must do an FNAC. Sometime on the FNAC, they do ICC, that's immunocytochemistry with calcitonin staining. But if you have a doubt, family history, patient has Marfanoid features, patient looks like they've got an MEN syndrome, you can just do a serum calcitonin. It's usually high in patients with medullary. So it supplements your diagnosis of medullary thyroid cancer.
Right. There is a case presentation, but very inadequate. So a patient having a vitamin D at 10 with a normal TSH and the blood calcium level is 11.9. Suspecting parathyroid. Now what next?
So very quickly, I'll tell you, this is parathyroid. It's fairly common because now
disturbing. Please mute yourself, other people.
We now have a lot of patients who come up with high calcium because it's so easily available. So whenever you have a high calcium, the first thing you do is to see the phosphorus levels and you see the vitamin D levels. If a patient has low vitamin D, you correct the vitamin D first. Usually the calcium will drop to normal after that. If it doesn't, you do a PTH. So you may have a slightly raised PTH in patients with hypovitaminosis rather than hyperparathyroidism. When the vitamin D is corrected and you still have a persistent hypercalcemia with a low phosphorus and a high PTH, then you will investigate the patient for primary hyperparathyroidism. Primary hyperparathyroidism is caused usually with a single gland in 80% of patients, a double gland in about 1 to 2% of patients. 10% of patients have hyperplasia where all 4 glands are involved, and about 1% of patients have a carcinoma of the parathyroid. Usually it's a single gland, and in a single gland you'll do 2 tests, an ultrasound and a system EB. If you have to do a CT scan, it has to be a 4D CT scan that looks at the dye going in and the washout. That is most accurate. So if you ever send for CT, it's a 4D CT. Otherwise, imaging, localizing which gland is bad, you do ultrasound and you do system EB scan.
A lot of questions still coming. What are the predisposing factors for thyroid cancer? Any biomarkers to predict the conditions first to prevent it? As you mentioned, the incidence of thyroid cancer is increasing.
No, the incidence is increasing. One is we are diagnosing more because of imaging, but some people believe that there is a true incidence in the increase of thyroid cancer, and I also believe in that. We don't know the cause. There are causes such as people in Hiroshima, Nagasaki, Chernobyl, wherever there was a nuclear fallout. Those people get a higher incidence of thyroid cancer. In parts of Kerala where thorium is very high in the soil, there may be a higher incidence of thyroid cancer. But for the majority of us, thyroid cancer, the real cause is not known if you don't have a family history or no syndrome to kind of predispose you to this cancer. I believe probably it has something to do with this aggressive iodinization. See, at one time, iodine was not really recommended. And a lot of people would have goiter, they would be born cretins and other things. Now it's compulsory to have salt with iodine. It's compulsory to fortify certain foods with iodine. Whether that is the cause, it's never been proven. But there seems to be a trend. There may be a clear indication. There's no way that you can predict unless young age, prior radiation, family history. In those patients, yes, you can preempt that this patient may go, particularly if it's medullary thyroid. So we scan those patients often with calcitonin and other tests, but otherwise you cannot predict. And don't be aggressive. Don't be aggressive to find it out. Otherwise, we land up with the Korea story in our country, and we don't want that.
Right. Any relation with goiter and malignancy, increase of malignancy in goiter cases?
So I showed you the meta-analysis that goiters usually have a lesser incidence of malignancy, but long-standing goiters can turn malignant, and it's usually a follicular thyroid cancer, long-standing goiters. So if you have a patient for a very long time with a goiter, it can change to follicular, and sometimes it can also become an anaplastic cancer, which is very, very bad. So if you have a big goiter, visible, it's safer to get your patient operated even if it's non-malignant. Many people will come and tell you, particularly those from smaller towns and villages, that they've had this goiter for 10-15 years. It's never caused them problems. The sub-Himalayan belt in our country, parts of UP and other places where water, the content of iodine in the water is less, those people have a lot of goiters. So certain belts we see, the Varanasi, that area, they have a lot of patients with goiters.
Thank you very much, Dr. D'Cruz. It was really enjoyable. It was nice to listen to you, and I hope everyone's questions are answered. Thyroid becoming more and more common, and we are seeing more and more of thyroid cases. This becomes a very important talk. Thank you very much.
Welcome, a pleasure. Thank you for having me, and I can answer questions offline as well. I gave you my coordinates. I'll be delighted to answer any questions. Thank you once again. All the best for the rest of the program.
Thank you very much.
Thank you, sir.
Now hand over the mic to Dr. Usha.
Yeah, the next speaker is Dr. Sandeep Bipte. He is a oncoplasty surgeon. To introduce the speaker, I call upon Dr. Komal Chatania. She is a IMA CGP member. Over to Komal Chatania.
Thank you, Dr. Usha. Dr. Sandeep Bipte is a specialist oncoplastic breast surgeon at Apollo Spectra Hospital, Navi Mumbai. He is also consultant breast surgeon at Jaslok, Hinduja, Raheja, and Fortis hospitals. He has done his MBBS and MS General Surgery from Nagpur University. He then completed fellowship and specialty training in breast oncosurgery from Tata Memorial Hospital, Mumbai. He has also undergone specialty training in intraoperative radiotherapy, that is IORT, at Whittington Hospital, London, UK, which is one of the novel treatments for early breast cancer. He has clinical excellence in diagnosis and management of benign and malignant breast diseases with over 250 to 300 breast surgeries performed yearly. His area of interest includes breast surgery of malignant diseases, breast reconstruction, that is oncoplasty, implants, expanders, pedicle flaps, targeted intraoperative radiotherapy, IORT, for early breast cancers, and BRCA, that is BRCA genetic clinics for patients with high risk for breast cancer. Dr. Bipte has been part of national and international conferences and training programs. He was invited as faculty in various national breast cancer conferences. Today, he will speak on breast oncoplastic surgery. Over to you, Dr. Sandeep Bipte.
Thank you, Dr. Komal. Am I audible?
Yes, yes.
Yes.
Thank you. So first of all, I'm very delighted to have this participant, 508 plus the participant. And thank you so much, Dr. Mehta, Dr. Lal, Dr. Neil, and the Apollo team for giving this wonderful opportunity to interact with you all. So today I'm going to, after listening Dr. De Cruz as a lecture, is thyroid. So it's an amazing lecture. We always, in spite of listening repeatedly, still we learn everything, new things. So I'm taking out this completely from a thyroid to a journey of breast surgery. Slides are visible?
Yeah.
Okay. So what the oncoplastic breast surgery is about? You heard about the mastectomy, the breast saving surgeries, but what the oncoplastic about? So this is every woman in the lifetime, the aesthetical, they want to look beautiful. But same female, when they had the breast cancer, especially they land up with the mastectomy, double mastectomy. So, the lifetime they become without reconstruction because of the lack of knowledge. So what the oncoplastics come in between. So this patient don't have right to look good, or they don't have a social image what. So this is just because a lack of the awareness about these the oncoplastic surgeries. A lot of patients always land up in the with the mastectomy, especially at the periphery area. So this is a bridge in between the breast saving surgery, mastectomy to the reconstruction. So this is a classic scenario how the practice deal in our area. So somebody who diagnosed breast cancer, had investigation, go to the surgeon, had mastectomy, and this lady will never have an option of reconstruction. So nobody thought about why she didn't have reconstruction, because whole lifetime she has to remain with one breast. A psychological, the factor, the social factor, the depression throughout, because nobody had offered him reconstruction. So because this was not, the people were not aware about the what oncoplastic surgery is about. The safety was not known. But today we are in the 2021. We should know it. So today that's why we are on this common forum to share this knowledge about this oncoplastic breast surgery. So this alone I cannot do this education without your help. So this is a exchange of the knowledge where you can transmit to your patient in your practice and they can get the best result outcome. 2 years back, we are having only MiG-21, and today we are Rafale. So this is same way. So once upon a time, if somebody would diagnose breast cancer, this lady will offer only mastectomy. But today we are in 2021. So this lady had a breast cancer surgery with oncoplastic surgery. So tell me, everyone want this type of surgery to be happen, not the mastectomy. So the things are changing, and we have to change with the time, with sharing the knowledge with each other. So breast cancer surgery has gone in a far shift in a paradigm because of the newer technology. So I remember when I was a resident doing a surgery, I used to do only a mastectomy, nobody thinking of talking only breast surgery. But today we are talking about a prophylactic mastectomy. This is a change which. This is a very classic slides we can to show. So a few years back, breast cancer, the only option was radical mastectomy, and the ladies to live a lifetime with one breast. Versus today, the Angela Jolie has set an example. She don't have breast cancer, but she had a strong family of breast cancer, and she had a BRCA gene positive. And today she went a double mastectomy with reconstruction, and today I see her image with the. So they act before something to happen. So the world is moving towards a very, very advanced technology. But still there's a disparity. Why in our country, why the patient's not happy? Because the brace is something which deal with everyone, from general practitioner to the brace surgeon. To reaching to the specialist, the patient had a lot of the level of the hurdles coming to the specialist, and that's why we cannot provide the best service available. So today's with this presentation, I'm sharing this my experience of the breast oncoplastic surgeries in last over 10 years, and you can give this option to your patient so that they can get the best outcome for this results. So what the oncoplastic breast surgery means? So what is bronchoplasty? Why we do? Which patients are suitable? And most importantly, is whether it's safe or not. Yes. So basically, if you go back to history in oncoplastic surgery, it started in 1980 to 2010. So these are the see the people in Europe and in Western countries started in 1980s. In that time, we were not apt for a routine breast surgery as well. So we are lagging behind 20, 30 years from our Western countries. Basically, oncoplastic breast surgery means is an expertise, a single person expertise who can take out the tumor safely out and do the reconstruction at the same time. So it is we have an opportunity because in a breast saving surgery we take out only small tumor with good margin, but whenever the tumor is large, we have an opportunity to take out the maximum tumor and we can have safety and making the breast aesthetically same as before. So this will it will help in practice. So it will avoid a lot of mastectomies. It will avoid the increase the rates of the breast cancer surgery with a good aesthetic outcome. So we should not offer a breast saving surgery with a bad aesthetic outcome. It's not acceptable. So this oncoplastic surgery has added the advent in breast saving surgery. So will you see, these are the few examples. See, this lady had outside, she came from outside country and she had mastectomy. Can you believe this is mastectomy? The whole breast is here. This another lady, she's had mastectomy, but see, whole breast is here. This lady had some breast surgery. So will you accept this type of cosmetic in 2021? No. Absolutely no. It's not acceptable. Otherwise, there's no role of doing a breast surgery. What we want in 2021 is a good aesthetic because of the good aesthetic look. So this lady had a breast saving surgery, and 5 years down the line, this young girl had breast saving surgery. Another, this is 35 years old. So all these had a breast cancer with good aesthetic outcome. So today we are reached at this platform with this help of the oncoplastic breast surgery. Will this acceptable? Yes, everyone will accept it. And it's like a one-day surgery. The patient comes in the morning surgery and evening they can go back on next day. It's just a daycare surgery. A lot of evidence supporting them. The fear was whether it's safe. So we had a lot of papers and the publication, the trials is still we are in the learning phase, but a lot of the data available showing its safety for this breast cancer, the oncoplastic breast surgeries. So it's in a, when the patient comes to a clinic, it's your good suggestion or good advice to the patient. What is the right option for this patient? If somebody comes with around say 40 years and had say multiple tumor in a one quadrant, generally people do offer only mastectomy, but that's not the case. We should have in back of the mind, yes, there's a word called oncoplastic breast surgery where the tumor will be out and the patient can save the breast. So you can offer a good option. Basically, oncoplastic breast surgery is a combining a plastic surgery technique along with the taking the tumor out. So, for example, this lady who had a breast lump here, somebody would have taken the scar on the tumor and take on the tumor, and the nipple goes inside, and the cosmetically the outcome is not good. By doing this technique, we're going to take out the tumor and making the breast aesthetically at the end of surgery. There are different techniques. We don't want to go to the in detail of the techniques. But this training I got in UK, still we are in the learning phase. In 2012, this is Fiona McNeil. She's the president of the United in UK Breast Association. So, what are the candidates? Who are the right candidate to pick for this oncoplastic breast surgery? So, basically, any lady who underwent planning to have a lumpectomy or mastectomy. But for example, if somebody had a small breast and a large tumor, so generally we offer only mastectomy. But with advent of this oncoplastic breast surgery, we can borrow a tissue from the breast itself or borrow a tissue from her own body and do a good the cosmetic results. So there are different techniques. Just to keep in mind, just keep in mind that wherever the tumor in the breast, we have so many different techniques. You know, we can do good the aesthetic, even though patient the lump is at upper outer quadrant or lower inner quadrant. Anyway, we have different techniques by which we can do a good the aesthetic results. So basically, there are two things. One is a volume displacement and volume replacement. Very simple technique. So whenever there's a cancer, there's a fear in the mind. You know, always patient come in the clinic say, "Doctor, pura ka pura nikal do." You might getting this conversation from the patient. Is आप थोड़ा extra nikal do. So what that extra means, because they fear of that the disease will come back. So in medical term we call as margin. So whenever the tumor is there, we could take out 1 to 2 centimeter of the gross margin. And when you take out this margin, the larger tissue, there will be a defect, and the defect will lead to the cosmetic deformity. To overcome this deformity, we have techniques called as a volume displacement and volume replacement. Simple technique. So either we can borrow from the breast itself, or we can borrow from a different part of the body. So is there any evidence for this surgery? Yes, there are a lot of evidence, and the safety is there. So good papers, good. We had the review from the the review, which state the oncoplastic breast surgery improves a margin clearance. So we had a opportunity to take out the maximum the tumor along with good margin, and with this oncoplastic surgery, we can give good aesthetic results. So for example, this is generally how we do it. So for example, somebody who had a breast cancer, the aim of this the tumor to taken out completely. You can take out this tumor. See, this is around 2 centimeter tumor, but we have taken out at least a 4 centimeter good gross margin. But what happens then? So with the advent, with the fear of the margin, we take out maximum tissue, but at result you can see that there is a big defect. And generally, in a few years back, we just close the skin, and patient comes a few years down the line, you see there's a scaphoid folding there, there's a deformity, and this lady is to live a whole life with this deformity. This deformity leads to a lot of depression and a social stigma in her routine behavior. So we can do a lot of oncoplastic surgery, we can fill this defect, and we can get good aesthetic results. So a few examples, say somebody who had a breast saving surgery. At that time, you know, the aim of the surgery was just to take out the tumor. And if you year down the line, if the lady comes to you for follow-up, you see this bad cosmosis. One breast lifted up. Can you see that? With this normal breast going down, the other breast is completely atrophic. And you know, there's a lot of depression among them. So why not offer today this type of surgery? So this lady had a breast saving surgery with oncoplastic technique. Another, this lady had a breast saving surgery with oncoplastic technique. So we can yield a fantastic phenomenal results today with the same technique. So see, these are the results. So this young girl who had a breast lump here in a upper inner quadrant. So in early days, what we used to do is we have to take out a tumor, incision on the tumor, and there will be a big scar on this area and deformity this area. With oncoplastic technique, we had just gone from a peri-areal incision, taken out the tumor out, and make this defect close with underlying tissue. Another example, see, very, very classic example today, we get around 50s and 60s because of the aging process, the breast dropped down, we call as ptosis in medical world. This lady, she is around 62, she came with a breast lump in the left breast, but she found to have only one breast lump. But when we operated, we found a multiple tumor that time. But before a few years back, we used to do a straight mastectomy for her. But with the advent of oncoplastic surgery, see, we had done a breast saving surgery with phenomenal results. So this is second day. The patient came in for surgery, and the second day the results. So the breast is lifted completely, and the tumor is out, and there are multiple tumor. We had taken out the whole quadrant and replaced with the underlying tissue, with own tissue, no drain. And this will also help us, because if only a breast saving surgery, this lady will have a lot of side effect of the radiation. Because of this, the breast broke down. My radiation oncologist will always concern about this dropey breast, because there is a side effect in an inflammatory area. There are a lot of burns, grade to grade toxicity. With advent of oncoplastic breast surgery, this area is completely open. Aesthetically, it's fine, and in terms of the side effect, there are minimal side effects will be there. Another example, we often get this type of breast, the large breast, almost the breast was touching the abdomen. If some lady comes to you with this with breast cancer, what do you offer about? Just taking out a tumor? No, we have to correct aesthetic component as well. So we did a reduction mammoplasty, and you can see the marking inappropriately. So we had marked this tumor and the area where the tumor is out, and at the end of the OT, see the result. A breast is completely both the nipple at same level. There is a reposition of the nipple. The excess tissue is out, and always in oncoplastic surgeries, the opposite side needs some correction to match the cosmetic factors. So there are a lot of papers about the reduction mammoplasty. So overall, in nutshell, we should understand there's a good safety about this procedure, and we can easily use in a. Will you accept this type of surgeries? No. So this lady had a mastectomy. See the basic surgeries. So whole breast is here, where the ideal mastectomy should look like this. The flap from clavicle, inframammary area, and axillary, the whole breast tissue has to go. So, or what Dr. DeCruz already mentioned, or a lot of work is a redo work, or in practice, 25 to 30% work is redo work because somebody, the patient did not come to the expert in initial stage. They keep on having to move in different places and lumpectomy and then some deformity. I'll show some picture later on. So this type of surgery you can avoid. You might heard about the oncoplastics, the prophylactic mastectomies. See, Angelina Jolie had driven the whole world 2-3 years back with her double mastectomy. So what we have seen first Mumbai first few surgery we did. So this girl, the lady 40 years old, she came with a strong family history of breast cancer. She had 3 members of the family had breast cancer, and she herself is a BRCA positive. So having said that she's BRCA positive, the chances of having the breast cancer is around 70 to 80% till the age of 80 years. So she was very, very high risk. So we discussed all the option about the surgery versus observation, and she opted for a reduction mammoplasty, and now it's 8 years. See the results. So this lady, we did a bilateral mastectomy with reconstruction. So this is nipple area complex. From this keyhole, we had done a complete mastectomy without removing a skin. This is called a skin sparing double mastectomy. So from this nipple is out and the whole the breast tissue is out, and her skin is normal. And this reconstruction is done by using her own DIP flap. So yeah, this is abdominal flap. We took the flap and we did the reconstruction. See, the aciculation is fantastic. The now it's 8 years, and she will have a minimal risk of having the breast cancer. With this prophylaxis surgery, we almost cut down the risk of breast cancer by around 90%. There are good evidence. The majority of the evidence confirm that around 80 to 100%, not 100%, but 80 to 95% reduction in the having the breast cancer by doing the prophylaxis surgery. Two more example. This is a young girl. She's 18 years old. You heard about the term called as thyroid tumor. So thyroid tumor generally keep on happening in younger age group. But one more entity is called as malignant thyroids. So this girl had a malignant some thyroids, 3 times surgery. You can see the scar. You can see the scar. So she had a first excision, second excision, third excision. And when she came to me, we had reviewed the report, and it turned out to be a malignant thyroid. So malignant thyroid, we need to do redo surgery. If she would be in some other place, definitely she would land up in a mastectomy. So at the age of 18 to 20, a mastectomy is not acceptable. So what we did did the complete quadrant excision. You can see that the whole area is marked. So this is 12 o'clock position. This is 3 o'clock position. Whole area is excised. You can see the defect. So I had excised all the area completely, a whole quadrant, and then I had to fill it. If you recollect the last slide, there was called as a volume displacement and volume replacement technique. So this is volume replacement. So I had excised the volume. Now I had to replace the volume. So where I should borrow from this volume? So this volume I got from the backside from her latissimus dorsi muscle. We call it LD muscle. I borrowed the muscle from here. It's a pedicle flap. Nicely put it inside and see this cosmetically. We have both nip. This is immediate results on table. This is immediate on table. So both the nipple are at the same place. Cosmetically, she have own tissue, and she will have a fair good cosmesis. So this is about a young girl. What about the elderly people? So this another lady, I have a 65 years old lady, and she was unmarried even, and she had multiple tumor in upper outer quadrant. But she said, doctor, even though I'm married, I don't want to remove my breast because this is my aesthetically, I want my breast to be there. So what we did a complete quadrant excision and we put the LD for her. And you can see that this is LD patch. You can see that we borrow the muscle from back side and aesthetically see she's on radiation and both the nipple at same side. And she's very, very happy. This another young girl who had a larger defect, a larger tumor. We excised and put in the LD. So age is no matter. So because of whether it be 20, it will be 30 or 60 or 90, age does not matter. As long as the aesthetic factors are important, we need to they respect the decision of the patient. This another girl she is a 30 years unmarried girl when she came to me with a large tumor. And we had given a chemotherapy and then the tumor was small, but the tumor was very, very big. So see, we did complete excision of tumor, whole quadrant is out and we put the LD muscle. You can see that LD muscle. Nicely, this LD muscle is put and see the costing aesthetically. So this type of result we can provide with a different technique. And in early days, the people were not trained. They have no awareness about this technique. So all these patients will land up in a mastectomy. Today's it's a legal way to not offering reconstruction to the patient because a lot of decision in our countries is taken by the family, not the patient. Nobody asks about it because it's a fact. Still in the Mumbai, when a patient comes to clinic, in full family, the patient is the last person to speak, and her whole decision is taken by the family. कि डॉक्टर साहब पूरा ब्रेस्ट निकाल दो, एक बार निकल जाएगा तो वापस नहीं आएगा. There's a lot of myths in the patient mind. But when you're offering a mastectomy, please do explain about the reconstruction, whether she will have, what option will have, we can always decide. So this lady always we can offer a good implant reconstruction. We can have our own tissue reconstruction. See, we can borrow own tissue and we can have reconstruction. Simple technique by putting just implant, we can have good reconstruction. So aesthetically, it's very, very important to offer them this type of the reconstruction. So few things about these, 2 slides about the sentinel node because the general practitioner who knows about that. You heard the word about the lymphedema. So a lot of patients do have come in a very advanced stage with the swelling in the hand, stating there's a lymphedema. Why this happened? So today we have come up with a very new technique called a sentinel node. We do inject the blue dye, and when the nodes are negative, the blue dye goes from here. This is the methylene blue dye. It goes one node, typical node. With the small centimeter incision, we take out this blue node, check it on table. If it's not affected, then there's no need to remove this the lymph node, and this is very, very one of the conservative approach. So a few 4 or 5 examples how the practice has been changed. So basically, this patient, all of the patient was advised mastectomy without reconstruction. So these are a few cases I had done in Apollo. So this lady was 45 years old lady, had 2-3 lumpectomies outside, and the report was benign thyroid tumor. 4th time again she came some surgeries and had the report said malignant thyroid with positive margin. The only option, will you accept this cosmesis? Absolutely no. See how the breast is distorted. So we'll not accept the cosmetic results. So what we did then, we did a mastectomy, but we did a reconstruction. So we got a whole breast to be removed, but we had offered him a reconstruction. And see, this is a 5th day, and the 5th day patient went home. This is a 10th day, the cosmetically. This lady would have even she came from Nagpur. She would have mastectomy at that place without a breast reconstruction. So this is the expertise where we can interview in reconstruction and give good aesthetic results. Another case, she was 33 years old lady, had multiple tumor. So see, she came with the multiple tumor in a 1 to 3 tumor in upper outer quadrant. So whenever a thought comes, always the doctors, surgeon advise, no, mastectomy kar do, because it's a multiple tumor, multifocal tumor. The chance of reconstruction is coming back. But so when we got the mammography, we saw 3 tumor here. Can you see that? The lymph node positivity, the 1, 2, 3 nodes are there, 3 lumps and the nodes. So, and all the biopsies we proven to be a breast cancer, all 3. So what are the option then? Is only the mastectomy is an option, breast cancer, whether it's safe to do multifocal or with reconstruction. So most important thing when dealing with a cancer is a safety is a priority. We always think first is a recurrence or safety, and along with if you can think of a safety, always are the oncoplastic surgeries. So this patient we discuss MDT and we offer a good wide excision along with the LD flap. So one more oncoplastic surgery. So whole from 12 o'clock to 3 o'clock, the whole area is out, and you can see that. And after a month's time, this aesthetically. She's a young girl, she's 36 years, and she said, "Doctor, I don't want to do mastectomy." So with oncoplastic technique, by putting a LD flap, we had given a good cosmesis, and she's happy. Another final case is 30 years old. A lady come with this central quadrant lump and nipple discharge. So whenever we have started teaching, since the medical school, if somebody came with the central tumor, the option is only to mastectomy. The biopsy was the IDC2, but what we did a new oncoplastic technique we call as donut technique. So like a donut, we can just we had excised this skin, and we had taken out the skin island out, reflect the NSC area, taken out the tumor completely from inside, and make the nice cosmetically results, and see the final is on table. So hardly visible scar, this is on table. So all these three examples I had shown, all they were advised to have a mastectomy outside, but with oncoplastic technique, we had saved the breast of all three patients. This is a lot of shift is happening in the oncology surgery. In my conclusion, so the oncoplastic surgeons have good level 2 evidence for the safety, and still we are in the learning phase. Although the Western countries are more trained, but in India we are still in a learning phase. But because of lack of awareness, this technique was not the concept was not passed on to the patient, because our own medical colleagues were not aware. So it's good tool to practice whenever it's needed. So my take-home message is a newer surgical option like oncoplastic reconstruction plays very, very integral role in treatment of breast cancer. Safety and cosmetic is proven in trials, but it has to be an MDT approach, because whenever we take a decision about the patient, we always call it multidisciplinary team approach. There are two, three surgeons. We discuss about this the best option available, and then we choose what is good for the patient. But still, we are more awareness is needed at this point about this thing. Thank you so much for your patience.
Thank you very much, Dr. Bipte. That was a wonderful discourse and a wonderful talk. There are a few questions.
Yes, sir.
One question is saying that when you do a surgery in a young lady,
yes, sir.
And after that, when she becomes pregnant and she goes in for lactation, does it affect the milk production, the quantity
Yes.
of milk produced, and does it also affect the latching, that is referring to the duct drainage and all that?
Right, very, very important and a practical question. So yes, it does affect it, but not per se the surgery, but the radiation as well. Because whenever you do a breast saving surgery, every patient has to have a radiation, and radiation impact throughout the breast, right? It's the impact of whole breast. So there's a good reduction of this in a production of this milk. If say, for example, if the lump is only in upper outer quadrant, if you take out the lump upper outer quadrant excision, there won't be a much reduction in the milk production. But with the addition of the radiation, there's a lot of fibrosis happen, which impacted overall.
Okay, so but percentage-wise, overall, what is your reading and what is your experience?
So generally, sir, we don't ask them to, because anyway, the somebody who had younger patient had breast cancer surgery, we avoid to have pregnancy at least for 3 years.
Okay.
Because so it always delayed. And anyways, at today's even though in normal delivery, 60 to 70% female doesn't have a normal production. They're on top of it. So with the one other breast, we can compensate this thing. But a good amount of 50% at least there will be reduction in the production.
Okay, one other question. Actually, this covers all oncologists.
Yes,
so
sir.
you do a preventive mastectomy in high-risk patients, right?
Right, sir.
So have you ever seen that these patients manifest in some other forms of cancers in the body?
So, sir, basically all these patients, like we call a high risk. So we always goes with the genetic history first, genetic counseling, and after genetic counseling, we do a certain germline mutation test. So, for example, if somebody had a strong family history of breast cancer, so 1, 2, 3 members of the family, and then they assess the risk of the breast cancer more. But somebody who had other cancer like a stomach and prostate cancer, so we had to assess the risks of the what cancer is predominantly going to happen, and according to we have to act that. So especially in a breast cancer, somebody who had BRCA1, BRCA2, we deal with that. But there might be a family association. Yes, they will not have the breast cancer, but they will have some other. We call it as a syndromic combination. They can have that. But number are very, very less.
Okay. Thank you very much, Dr. Bipte. That was a wonderful talk and very nicely answered question.
My pleasure, sir. Thank you so much for this lovely opportunity.
Please carry forward. Dr. Usha, please unmute yourself. Unmute yourself.
Yeah. Thank you so much, Dr. Jitesh Mehta. Now the next speaker is Dr. Ashwin Tamankar, and he is a uro-oncologist. And to introduce the speaker, I call upon Dr. Kashyap Dakshini. I am a CGP member. Dr. Kashyap.
Good afternoon, friends. Dr. Ashwin Tamhankar is a consultant in uro-oncology and robotic surgery, Apollo Cancer Centers, Navi Mumbai. After doing his MBBS and MS in general surgery from GS Medical College and KEM Hospital, he pursued MCH urology from LTMMC and Sion Hospital. He then received Vatikuti Robotic Uro-oncology Fellowship from Max Institute of Cancer Care, New Delhi, Olympus AINU Laparoscopic Fellowship from Asian Institute of Nephrology and Urology, Fellowship in Uro-oncology from Tata Cancer Research Memorial Institute, and Robotic Urology Fellowship from Royal College of Surgeons of England. He has been a part of over 280 robotic procedures in urology, being the primary surgeon in approximately 90 cases. His areas of interest include robotic-assisted radical prostatectomy for prostate cancer, open or robot-assisted radical cystectomy for bladder cancer, open or robot-assisted radical nephrouretectomy for upper tract urothelial cancer, robot-assisted partial or radical nephrectomy for kidney cancer, and surgeries for penile and testicular cancer. He is a member of the panel for formulation of guidelines on uro-oncology for the Urological Society of India. He has published extensively in the field of uro-oncology, and he holds 48 peer-reviewed publications in various international and national journals. He has presented 30 papers in various national and international urology conferences. Today, he will speak on the introduction to uro-oncology and robotic surgery.
Thank you so much, sir. Thank you so much for the kind introduction, and I highly appreciate the opportunity. Sincere thanks to Dr. Jitesh Mehta, Dr. Girish Lad, Dr. Usha Shah, Dr. Kajal Ahuja, and the entire Mumbai IMA community. And it's always good to be a part of. It's always good to be a part of Mumbai IMA Association. So today I have a couple of presentations. First is to give you a brief about what uro-oncology means. I hope my screen is visible and I'm audible, right?
You're audible, yes.
Yeah, yes, thanks. So first presentation will be a bit on what uro-oncology means, just to sensitize ourselves a bit more about uro-oncology, to know about incidences, prevalences, a little bit about risk factors of these uro-oncological cancers. And the second presentation, I will talk about role of robot pertinent to uro-oncological cancers. So obviously, uro-oncology is a niche area of expertise where we are focusing on cancers related to the urology field and male genital organs. So if I may represent into the diagram, it includes adrenals, kidney cancers, cancers coming from the ureteric lining called upper tract urothelial cancers, from the bladder, prostate, male genital organs, penile and urethral cancers, and female urethral cancers as well. So it is always a disease management group. It's not an effort done by a single person. It's always a joint venture done by 5 to 6 group of people. One is radiation oncology, another is medical oncology. The most important pillar again is surgical oncology or the uro-oncology in my field, a dedicated pathologist, radiologist, and nuclear physicist. Probably we are listening to this particular agenda since the first talk of Dr. D. Cruz, that we need to have a dedicated focus, not just from the surgical aspect, but from the pathological aspect, from the radiological aspects. So more and more you practice or consolidate into one particular area, more your skills are getting sharpened. So at Apollo, it's a center of excellence for cancer care, and it's an institute of robotic surgery. The information is widely available on the website. We have Da Vinci robotic system in which we can perform robotic surgeries. We have high-end machines for TrueBeam. I'm sure Dipali must be talking about the radiation subsequently. We have machines for PSMA PET scans, and needless to say that it's a JCI accredited hospital with international standards. So coming to the uro-oncology, global burden of uro-oncological cancers is increasing. Compared to 1990, in last 2 to 3 decades, the incidence is hiked significantly. In urogenital cancers would attribute to about 1/5 of total cancers. This also includes female genital organs, but in general, the urogenital cancer incidence is nearly 1/5 across globe as well as in India. The color-coded map will obviously tell us that even in India, the each and every state is changed into a higher version of incidence and prevalence for uro-oncological cancers. Prostate, kidney, bladder has jumped into the high order of a sequence as per the incidence and prevalence rates. So coming to the prostate cancer, across the globe, it is the second most common cancer. In India, unfortunately, it is little underreported because we do not have a robust screening system for prostate cancer. I'll be talking in brief about it in the next slide. So it's a second most common cancer, and soon it will overtake lung cancers, and it will be a most common cancer in gentlemen across the globe. Nearly 1.3 million, 13 lakh people are diagnosed with prostate cancer annually, and 3.5 lakh people succumb to prostate cancer as per 2018 data. This is a kind of eye opener figure, which I should say. At the age of 80, if you autopsy every gentleman, probably you will have 60% of these cancers. Obviously, not every prostate cancer or early prostate cancer at this particular age of 18 needs a therapy, but incidence and prevalence is much higher, and India, we are a little underreporting it. So if you see the figures in USA, last 4 years, if you represent, the incidence numbers are increasing, the deaths are increasing. So in 2020, the statistics would mention that a man will be diagnosed with prostate cancer in USA every 2.7 minutes, and a man will be succumbing to the prostate cancer every 16 minutes, which is a harsh reality. In India, we do not have these numbers. I'm very sure all of us know that majority of the occurrence in Indian standards, we get patients in a late stage or a metastatic stage where they start having bone pains, they start having paraplegias, they start having bleeding in the urine, and a window of opportunity to cure the patient is lost. So what is happening in India? A TOI article does mention, that's the data coming from ICMR, that's as per the Mumbai, Chennai, Barshi, and Bengaluru. These are the different cancer repositories which we have. The incidence is increasing, nearly 7.5 per 100,000 population in India. We stand at that point of time. So a little bit about the role of screening. Though it is not a very robust modality in India, in Western countries, it's a standard norm for every gentleman to undergo this particular screening. Why so? Because we have a robust data now coming from European randomized study for prostate cancer, which tells us that in long-term follow-up, they publish their data at 4 intervals at 9 years follow-up, 11, 13, 16, and believe me, that's a very significant, huge amount of follow-up. So at 16 years follow-up, every year, every time they are coming up with some more follow-up, the number needed to screen to prevent one death is decreasing, and number needed to treat to prevent one death is decreasing as well. That means screening is working well. Nearly 21% reduction in the mortality and 30% reduction in the chance of getting cancer detected in the advanced or the metastatic stage. So as per the guidelines, screening for every gentleman, he should undergo 2 tests as a part of screening: PSA and the digital rectal examination. So serum PSA and the DRE are the essential pillars of screening of prostate cancer. And European people will recommend more than 50 years, of between 50 to 70 years, they would recommend individuals to undergo this particular test. American standards are between 55 to 69. I'll have a word about upper limit here, because upper limit is as per the previous literature, but age is just a number. A patient who is extremely fit, who is extremely fine, his chronological age and the biological age may vary, and the biological age may be much lesser than the chronological age. So upper age for the screening we can decide based on the fitness of the patient, but at least we should start screening our patients beyond the age of 50. Every gentleman should undergo this particular test once a year, and subsequently any abnormalities in these 2 tests would percolate into possibility of MRI and a possibility of biopsy to pick up early cancers. So coming to the bladder cancer, it's a 7th most common cancer in gentlemen, and in general overall 11th most common cancer. Male to female ratio for incidence is about 9 and 2.2 per 100,000 across the globe, and death ratio likewise is nearly 3.2 and 0.9 per 100,000 population. Surprisingly little lesser in females. There are two main reasons for it: because of the smoking, which contributes to the bladder cancer to the core. So 50% of the cases of bladder cancer are ex-smokers or existing smokers, and nearly 10% of the remaining individuals have history of some environmental exposure. Mumbai being the hub of environmental, the chemical industries, we have a lot of patients who are related to the environmental exposure for bladder cancer coming from rubber, textile, dye, chemical, petroleum, and leather industries. ICMR data again does mention that as the reporting is getting better and better, the incidence and prevalence of bladder cancer is increasing as well. A quick word about what hematuria means and what we should be, as in who are the risk individuals, at-risk individuals for having a cancer, either in the kidney or the bladder when they are presenting with hematuria. So hematuria is nearly about 20% of all urological evaluations, and it translates into 10% rate of urinary tract cancers, especially if you have gross hematuria. That means visible hematuria. If the patient is complaining of hematuria himself, nearly 13% will be of them will be having a cancer of urinary system, either kidney, bladder, or the lining of the ureter. And 3.1% out of microscopic hematuria will have will have these particular cancers. As per the British norms or British registries, 1 in 5 individuals of gross hematuria and 1 in 12 individuals of microscopic hematuria will particularly have bladder cancer. So which are the individuals at risk? Age obviously is the magic number. Nearly beyond 50s and 60s individuals are at high risk. Male sex again is at high risk for having a cancer, as we already discussed, because high incidence for bladder cancer occurs in male. Smoking is most important risk. Degree of hematuria, microscopic hematuria. So on the examination report, if you have more than 25 RBCs per hypofield, so they divide it based on 5 to 10, 10 to 25, and more than 25. So if you have higher the number, higher is the possibility of cancer. Persistence of microscopic hematuria. If you have a couple of reports on a variable interval where there is a microscopic hematuria, the risk increases. Obviously, gross hematuria escalates the risk of any cancer of urinary system to a very core extent. Previous radiation, previous drugs which are related to inducing the effects of bladder cancer, previous history of urothelial cancers or some other cancers in the family, and lower urinary tract symptoms. These are the individuals who should be screened. A quick word on the workup of these individuals. Obviously, gross hematuria should be evaluated with obviously urine routine and cultures to rule out the infections. PSA comes as a part of examination in men. Urine cytology is one important pillar. Generally, it is not done in a gross hematuria. Cystoscopy is the another camera test where we diagnose as well as proceed for the therapeutic intervention for scooping out the bladder tumors, and a CT to pick up masses in the kidney or the ureter or the bladder. So these are the 5 pillars of workup of a hematuria candidate. Coming to the kidney cancer incidence is increasing. In India, we have surprising magic numbers. In global literature, if the mean age is about 65, we are at 56. So we are nearly 9 years, or I should say a decade younger in the incidence rates for kidney cancer, which is an alarming sign. And it is a paper coming from Tata Memorial Hospital. 1/3 of these individuals in India are less than 50. Again an alarming number. Only across the globe, if you see a very small tumor is detected to 60%, as in people presenting with small tumor attribute to 60% of all kidney cancers. In India, this number is only 10%, meaning more than 90% of the patients, or nearly 90% of the kidney cancer patients, are diagnosed in a stage beyond 4 centimeters, where the possibility of partly saving the kidney or a partial nephrectomy becomes compromised. Hence, again, an alarming figure here. Male to female ratio is 4:1, doesn't have any genetic association per se, but probably because of this attention to seek medical care is the reason for this differential numbers. Risk factors for kidney cancer. Recently, we had Kidney Cancer Awareness Day on 17th of this month. And the risk factors, we had a nice talk across the pan-India Apollo campuses on uro-oncology. I spoke about the risk factors of kidney cancers to create more awareness. So smoking, obesity, hypertension, and chronic kidney disease, these are the most important risk factors for kidney cancers. If you see the trend, as per the low and low socio-demographic index countries, which are represented in dark blue and the red map, the incidence is going to be slowly increasing until 2030. So we are still in that phase. The middle high and high is SDI countries, or the, I should say, developed countries. The incidence is now slowly coming down, but in India, until 2030 at least, we are increasing with the incidence rates of kidney cancers again. Penile cancers, though they are relatively uncommon, India is a hub of penile cancer because it is directly associated with poor socioeconomic status, as well as lack of awareness to come forward for seeking a medical health. Rural areas, the incidence is increasing. Urban, it is fairly static. So if you see Barshi and other areas will have high incidence of penile cancers as compared to the urban countries, and we get a lot of patients from referred as a referral unit for urological cancers from different parts. So about testicular cancer, it is a common, though a relatively uncommon cancer, I should say, but it attributes to 5% of urological cancers, a most common cancer between the age of third and fourth decade, incidence of less than 1 per 100,000 population, and we should be screening, as in testicular self-examination should be a norm which should be taught to the individual, and it should be a part of normal health evaluation. I will quickly share another small PPT on role of robotic surgery for urological cancers. Yeah, I hope my slides are visible again. So role of robotic surgery for uro-oncology, exploring the neophront. I will be taking you all through the journey of different sort of cases which we have done at Apollo and what all implications we can have for utilization of robots for managing uro-oncological cancers. So these are my disclosures. I am a Da Vinci Fellowship trained robotic surgeon. I have done a couple of robotic fellowships, one in Delhi. These are dedicated 1 year hands-on fellowships, one in Delhi Max, and another was in UK under the aegis of Royal College of Surgeon and British Association of Urological Surgeon. And in this particular presentation, I'm trying to be little vocal for local, meaning I'll be quoting some data or the papers in which I have contributed to the core rather than quoting numbers or papers from the Western countries. So I am not very much into investments, to be honest, but this is a very alarming or very reassuring number for everyone who are more into investments. So global robotic surgery markets are growing faster than humans can handle. The robotic surgery was developed or established in the year 2000. It's been nearly 2 decades of journey for robotic surgeries, and there is a sea change in the utilization of robot for different types of surgeries, and not just uro-oncology. All other specialties, including gynae, colorectal, thoracic, are utilizing the robot to the maximal extent as per the indications. So compounded annual growth rate across the globe is nearly 9.6, which is probably a very big number. Nearly 5,000 systems are existing at the moment in the globe, nearly more than 80 in India. More than 5 million surgeries been done with the robot in last 2 decades. Where do we stand in India? That CAGR, which was 9.5 in world, is about 20.4 in India. So we are little late to take it up, but we are much faster to take it up. And that's a sign which I can give it to people who are more into investments. Though there is a disclaimer which I said I am not very much into investments, to be honest. So prostate, and for uro-oncology, any robotic major chunk of any robotic program or robotic work is uro-oncology firstly, and amongst uro-oncology surgeries, most important things are prostate and partial nephrectomies. I was fortunate to give a talk on newer robots. Till now, there was a single system of Da Vinci surgical system existing so far. But in last 1 year, there is another system which is installed, and another few systems are going to be installed in next couple of years. And the future is bright, meaning the cost of the robotic surgery is going to come down. I should put it the other way. The cost is actually not too high at this point of time now. So cost, we always used to debate about the robot based on the cost, but as compared to the results which we are getting, the cost is never a hurdle, or cost is never an Achilles heel anymore now. I'll be quoting about some cost figures in the end on this particular talk. So let me take you all through different types of organs in which this robot can be used for uro-oncology. So prostate cancer is the most important cancer, or the highest volume cancer, which is operated with the robot. There is a reason for it. It is difficult to operate in an open or a laparoscopic manner for a prostate which is hidden in the pelvic brim, and the maneuverability of the instruments is much important for taking out the prostate. So if you understand the difference between open and a minimal invasive surgery, obviously we know that there is a big scar in open surgery against to a small multiple ports of robot, or the laparoscopy in minimal invasive surgery. For the robot, it has a magnified view. We can spare the nerves. Because of that, we have 7 degrees of freedom, meaning it is the wristed motion of the robot is even more than a normal human wrist can offer. Absolute precision and control is the main key pillar of robotic surgery, because of which we have hardly any blood loss. We do not transfuse patients of radical prostatectomy. We have faster recovery and early discharge. Patient generally goes home within 2 days. So fairly a painless recovery. So 3 scenarios of prostate cancer I'm going to discuss with you all. One is a screen detected prostate cancer, in which the cancer is actually confined to the organ, similar to what Dr. Bipte was talking for organ confined or early type of breast cancer. Similarly, for early type of prostate cancer, robotic prostate surgery is the key pillar of any management, because we can beautifully spare the bladder neck with the robot. We can spare the nerves for giving some sexual outcomes to the patient as well. The history or the factor which is often neglected in India, but not anymore. So that's a small snippet of the robotic surgery for the prostate. So that's the pubic brim. We are actually sitting inside the tummy of the patient. On the robotic console, we always get a 3-dimensional view. Obviously, this is a 2-dimensional view in the recording. So these are the instruments of the robot. I'm actually sitting not next to the patient. I'm sitting on the console, away from the patient, and operating from a distance. And a separate surgeon is helping me out for some minor instrument changes by sitting at the bedside. So that's the prostate, that's the bladder neck. We are trying to dissect the prostate from the bladder to scoop out the bladder neck. So I'll just fast forward the video a bit. So if you can imagine this particular vision is never an imagination in open surgery. So this is a bladder neck. We are trying to actually scoop it out 270 degrees from the prostate, and we are going to try and spare the bladder neck. So in the end, once these are the seminal vesicles, once the prostate comes out, if you can imagine, that's the bladder neck which is spared. The prostate which was lying here is already been taken out, and we are going to join the bladder neck with the urethra now. And what is the meaning of continent bladder neck on table or a spared bladder neck is, sorry. Yeah. So we actually need to push the urine out of the bladder on table, meaning that the bladder neck is spared nicely. So what is the meaning of nerve spare? What we do, like I said, it's a team effort. I always say, for example, I have a prostate tomorrow, I have another prostate on Thursday, and another prostate on Monday. So what we do routinely is we sit with the radiologist, we sit with the pathologist in the post-operative phase, talk to them about the scans, find out about the disease. So in this, he was a young gentleman with a disease more low. That's the prostate, that's the bladder on the MRI. The disease was more on the left side. That's why we wanted to stay a little away from the prostate on the left side and spare the nerve on the right side. And that is what we did during the surgery. That's a video on demonstration of the nerve spare on a specimen of the prostatectomy. So what we did was we spared the nerves on the right side, and so if you see on the right side, as the disease was more on the left side and the right side, there wasn't any disease coming to the periphery. We wanted to stay flush to the prostate. That's the bare glistening capsule of the prostate, and hence we spared the nerves which were lying here, which are still existing in the body of the patient. That will translate into sexual recovery. And on the left side, the disease was coming close to the capsule. That's why we kept a little bit of fatty tissue, if you can appreciate, to spare the nerves, but not to go very close to the prostate, simultaneously not to knock out the complete nerves as well. So the second scenario, high risk cancer. In the open era, the high risk cancers were never for surgery or complete removal of the robotic prostate by radical prostatectomy. But with the robot, with the advent of the robot, the possibility of surgery of a patient who is on a catheter, or possibility of a patient who has a high risk locally advanced cancer where the cancer cells have gone to the seminal vesicles or to the nodes, is a feasible option. And we regularly perform these kind of surgeries. Tomorrow the gentleman is on a catheter, and the gentleman on Thursday is also on a catheter, whom we are going to offer the robotic surgery for prostate. So what all are the advantages of these multimodality management? So like I said, it's a team effort. I operate the patient to give a lot of good local control. Pathological representation becomes very well. There is a possibility of requiring radiation in the post-operative setting for high-risk prostate cancers to keep the patient under good health for better translation into survivals, including cancer-specific survival and the overall survival. And the nodal stage becomes most accurate, and hence we can decide about the hormone therapy at a later juncture. There's a lot of work. These are few representative slides, but there's a lot of work going on in high-risk prostate cancer. It's a very heated discussion at this point of time into uro-oncological field. A word on the oligometastatic prostate cancer, meaning that's a third stage where we can actually find out the prostate cancer, where the cancer cells have gone out of the prostate into either lymph nodes which are at distance, or early type of bony disease, up to 4 or 5 bony lesions where we call it oligometastatic cancer. And in that particular situation, we treat the local prostate either by radiation or eventually in future by surgery. Then the survival translates into better manner. So these are the trials which have offered good results based on the radiation to the local prostatic bed, even for oligometastatic cancer. And believe me, there are 9 trials currently going on for exploring the role of cytoreductive prostatectomy, meaning removal of the prostate in an oligometastatic setting, and we will have the results soon. So few slides on the work which I have done so far for the prostate cancer and the robot. So majority of these patients are quite old. They are already on aspirin because of the risk factors, because of the cardiac conditions, and they can be safely continued on the aspirin, which we proved, and it is a paper published in one of the USA journals. Another randomized trials which we explored the role of anesthesia in keeping a intracranial patients safe during the surgery, because patients are in a head low position during the robotic surgery. Like I said, age is just a number. We have a data of more than 75. Obviously, not every individual beyond 70 would be offered this kind of therapy or surgery, but extremely fit individuals with less of comorbidities who have good life expectancy can very well be offered robotic surgeries to prostate. I have a gentleman who is 75 and 78 who has undergone a robotic prostatectomy, and they did phenomenally well including perioperative process, as well as the complication rates, as well as the functional outcomes of urinary continence. There are 2 ways of doing prostate biopsy. In India, the second, I was the one who analyzed the entire data of 500,000, 5 lakh prostate biopsy in the UK NHS done over 1 decade. And we explored the data between perineal and the transrectal biopsies, and mentioned that transperineal scores over transrectal in terms of reduced infection, sepsis, and hence the cost. So transperineal is the way forward. We are trying to get that at Apollo very soon for getting the biopsies done. We also evaluated the data on lymph node positive prostate cancer patients, where the India is the hub. Many people in India, we get a lot of locally advanced cancers, and many people have lymph node positive disease, and we are the ones who are giving the data out to the entire globe for assessing the role of hormone therapy in these particular settings. This is a data which comes from my fellowship days in the UK, where we actually are sending sample of the prostate for frozen section. So the world is moving to a very rapid pace for prostate cancer management and robotic prostate cancer management. I think that was on the prostate. Few slides on the cystectomy and the nephrectomy. So cystectomy, again, robotic role of cystectomy is picking up very highly now. In general, we have nearly across the globe, nearly 50% or 46% of the cystectomy has been done in Europe and North America robotically now. And I analyzed the data in the UK NHS for about 12,600 cystectomies in last 6 years, and in UK, currently 40% of the cystectomies are being done robotically. Believe me, UK is a very stringent system. They look into the cost, they look into the outcomes. It's unlike America, where everything is insurance based. So UK people are the ones which are late believers on any policy, because they want a time tested thing, and if they are adapting to something, that means there is some advantage in that. So the current numbers or the figures in after 2019 are hiked to 60% now. So 60% or more than 50% of the robotic cystectomy surgeries are being done robotically across the globe. There is a reason for it. The length of stay is much lesser. There is a difference of nearly 3 days between the open arm and the robotic arm for cystectomy. The painless recovery, the faster recovery are the Achilles heel of I should say, these were the Achilles heel for open surgery, and these are the advantages of robotic surgery now. The cost is never a hurdle. I'll quote another paper in that. We all implement ERAS protocols, meaning enhanced recovery after surgery protocols for all robotic surgeries, and cystectomy is a central pillar for that. We did analyze the data, which is published in Indian Journal of Urology, which gives us adequate results on ERAS principles. Again, a concept of teamwork here. So every time when I speak about core work, I will always embark on the teamwork. So I call it Pandavas. It's a dedicated effort done by a group of surgeon fellows, a dedicated nurse, a fixed anesthetist who is looking after the patients in the perioperative phase. And we got the national prize for this particular paper in the Urological Society of India. So again, the cost which we spoke about, as Dr. De Cruz was saying, more than 30 thyroid surgeries a year would translate into less of cost, good results. Similar way for cystectomies. Only 7 cases of cystectomy per year translates into better outcomes, as well as equivalent cost as compared to open surgery. And a hospital data, if you consider, more than 19 cases a year, which is not a big number, and hence the cost is never a hurdle now anymore. A little bit about the nephrectomy. Though for radical nephrectomy, meaning the complete removal of the kidney, robot and the laparoscopic approaches are fairly equal. Robot is being utilized more and more because of the comfort to the surgeon as well as to the patient, and a faster recovery with three-dimensional vision with less of complications, and hence nearly 40% of the nephrectomies are being done robotically now. This is the second most important valid indication of utilization of the robot for uro-oncological surgeries, first being prostate, second being this partial removal of the kidney, and third being cystectomy. So partial of the removal of the kidney, robot scores over any other surgery, open or a laparoscopic surgery by all means. Compared to open surgery, robotic surgery had low morbidity. It's a meta-analysis. It's a level 1 evidence. There can't be a evidence beyond this. Lower morbidity and achieves similar functional outcomes, similar to laparoscopy. If you say RPN stands for robotic partial nephrectomy, LPN stands for laparoscopic partial nephrectomy. So robotic partial nephrectomy scores over laparoscopic partial nephrectomy in terms of lesser conversion to open, lesser conversion to complete radical removal of surgery inadvertently because of the bleeding, less ischemia times, better functional preservation of the kidney functions, and less of length of stay. So robot scores over laparoscopy for partial nephrectomy by all means. So this is how the future would be. In fact, not just future, people are actually utilizing this in Western countries. They're actually having a 3D printed models with artificial intelligence. They are evaluating a tumor which is located in a tricky situation. That's a horseshoe kidney, or a maldeveloped kidney with kidney tumor with multiple vessels feeding the kidney. So they are actually amalgamating the data on the scans with the 3D printed models, and they are virtually performing a surgery a day prior to the surgery on a simulation, so as to understand the difficult steps to prevent actual complications when they are performing the live surgery on the next day in the patient actually. So that is the way the future is going to be, and we are definitely not lacking in this. We will be getting there very soon in coming few years. Again, we analyze the data of urothelial cancers. That is these are the cancers coming from the ureter, where we evaluated the role of robot, which comes equal. So last few slides on the surgeries which are relatively rarely done, which are relatively atypical surgeries in the uro-oncological field. I was fortunate to be part of these particular studies when I was a fellow in Delhi or the UK. So total pelvic examination is a joint surgery done by the GI surgical oncology and a uro-oncology team, where we knock out the bladder, the sigmoid colon, the rectum, or in females along with the uterus. We knock out the entire thing for cancers coming from soft tissue tumors of the bladder or the seminal vesicles or the rectum. So we got the best possible video for this particular robotic pelvic examination in the Brazilian Journal of Urology. Similarly, the robot is being utilized for high-end surgeries like the tumors which are coming from kidney going into the vena cava, where we are utilizing the robot for early type of vena caval invasion for the patients. That's a very important valid indication of utilization of the robot. I would say fourth most important indication of robot in uro-oncology, that's video endoscopic inguinal lymph node dissection. We all know that the main hurdle or the Achilles heel for the groin node dissection in the penile cancer is wound infections and flap complications. With the robot, these complications are absolutely nil, and these particular surgeries are being utilized more and more, and we have published our video in Brazilian Journal of Urology. A word about retroperitoneal lymph node dissection. We all know that RPLND is an extremely challenging surgery done in an open manner as well. After getting enough proficiency in open surgeries and robotic surgeries, one can venture into these robotic RPLNDs. Of course, that was a case done by my mentor in Delhi, where with the video of that was invited into the International Conference of European Urology, and that was the only video presented across the globe in year 2018 on this particular topic. And I was fortunate for the opportunity to present that amongst all European urologists. So the future is bright. Most important thing here, again, few things which we are doing at Apollo. So we are regularly doing genetic analysis for prostate cancer, which is often missed out by many of us. Many of urologists, many of our colleagues also may not be venturing into it. It's a central pillar now for management of prostate cancer in a metastatic setting or a high risk setting. We are trying to get that for family counseling, for better prognostication of the patient, as well as implications to pass on the genes to the second generation. We are regularly involving ourselves into teaching activities. These are the residents from all Mumbai urology campuses, KEM, Sayan, Nair, JJ, and New Mumbai campuses, MGM and the DY Patil. where they came for learning about the robotics at Apollo hospitals. We recently organized a massive event on bladder cancer in the month of May, which happens to be the awareness month for the bladder cancer. And Dr. Ashish Kamath, as an international faculty, we had 7 international faculties talking about bladder cancer, including 46 national faculties, and we had phenomenal response on learning opportunities of this bladder cancer. All of us know that we have some limitation. Not every surgery in the uro-oncology can be done robotically. We are core uro-oncologists first before robotic surgeons. So the core uro-oncology stands as the priority over robotic surgery always. These are the surgeries which I have done at Apollo in an open manner, where the robot utilization would be compromising the outcomes, and always patient comes first. Primum non nocere is the first principle, and then we decide about utilization of the robot. So wherever it is indicated to conventionally go with an open manner, we do not hesitate but to offer open surgery or a laparoscopic surgery for a particular tumor. Nothing is without admiring the efforts of your teachers or mentors, we can't progress. These are the ones who have taught me that. That's Dr. Gagan Gautam from Delhi, who taught me about the robot in Delhi. These are my teachers, Dr. Bakshi and Dr. Gagan Prakash from Tata Memorial Hospital. And these are the team that was a team of 5 great teachers from UK who taught me about the robot for 1 complete year in year 2008, 19 and 20. So you need to be improving your outcomes. You need to be learning forever to become better and better. You need to be having a focused area of interest. Few learning points which I should summarize. PSA screening for uro-oncology is a niche area of expertise. PSA screening is an important pillar which is often missed out by many of us in India. Beyond 50 to 70 years, every gentleman should be undergoing this particular test. We have it at Apollo in only 999 rupees. We are offering PSA, urine routine examination, and a free consultation from my end to rule out prostate cancer. Is more to create awareness rather than making money, to be honest. So we are trying to do that at Apollo. We have screened nearly 45 individuals so far, many people coming from DRC, ONGC groups, and we have detected 1 cancer of these 45 individuals, for which I actually feel very happy about myself. And so that was about PSA. Hematuria is another alarming sign which often is neglected by all these patients. So any sign of hematuria should not be neglected at all, and that should be reported and evaluated. I think I'll end over here. I will be happy to answer any sort of questions, and sincere thank you for giving us the opportunity to present in such a August gathering of 510 doctors across all Mumbai campuses. Thank you so much.
Thank you, Dr. Ashwin Samankar. That was a very, very extensive and very informative talk.
Thank you, sir.
We tried to cover a lot of things. I think it's a very vast subject. We can start with some questions, and we'll start with the PSA right away. So, are there any difference in guidelines of doing PSA in different countries? Can you just highlight on that?
Yeah, so like I said, American guidelines would say PSA will be done between 55 to 69. That was based on 1 randomized study. They would not do it beyond 69 so far, mentioning that there may not be a translatable advantage in terms of survival. But like I said, if the patient is extremely fit, we may not hesitate. Obviously, we may not do it beyond 75. But so Americans will follow 55 to 69 norm as per the standards as of now. Europeans will follow 50 to 70 as per the standards. European guideline will also say that in patients who have a family history of prostate cancer. So that is also another thing which I regularly do it in my practice. A patient who is diagnosed with prostate cancer, getting operated with robotic prostate. At the end of the talk, I always reinforce this to the son of the patient that you yourself should be getting screened for the prostate cancer starting from the age of 45. So 5 years earlier in them, because they have a high risk, their risk quotient is little more than mine. So 1.7, precisely 1.7 times my mine. Than mine. So for those who have a high risk history, 45 onwards. So there is a little variation. India, we do not have a robust data. Like I said, still we get a lot of patients in metastatic setting. I do more orchectomies or more evaluations of metastatic than robotic prostatectomies, to be honest, but I wish it will be the other way in next few years to come.
So they say that prostate cancer is a very slow growing cancer, and if God gave us a choice, then we would always go for a prostate cancer.
Yes.
But then the Gleason score does matter. Sometimes it becomes very fast growing. So what is the incidence of the Gleason score going high and very high, fast growing cancers in prostate in India?
Yes, sir. So India, if you take a general consensus amongst all urological conferences, everyone will say the same thing, that we have high risk cancers, firstly not just based on the volume of the cancer, but based on the Gleason score. So high risk cancer, more of Gleason 7, 8, 9, 10, which are coming up in India. Secondly, we have more locally advanced cancers. So they have disease coming out of the prostate capsule, going to the seminal vesicle or the nose. So uniformly in India, we have a lot of high risk cancers. If I can take you back, I'll not share the screen again, but there was a quick slide on the lymph node positive data coming from my own fellowship days. So we analyzed the data of 100 lymph node positive patients from my mentor's fellowship database when I was a fellow there in Delhi. I'll believe me, sir, in UK, when I worked for 1 year, indication for lymph node removal for prostate cancer during robotic prostatectomy was only 20%. In India, we 95% of the times we take out the lymph node because the disease are high risk. And out of those, many patients, at least 10 to 15% of the patients turn out to be lymph node positive on pathology. And unlike UK or Western countries where only 1% of the people will have positive lymph nodes. So comparing the databases, these 100 lymph node positive patients were coming from nearly 600 robotic prostate surgery database, whereas the UK will have less than 1% from probably 12,000 prostatectomy database. So there is a vast difference in the nature of the disease. All of us know that we are dealing with a high risk disease here, which can't be monitored at all. So the routine norm that prostate cancer, you just do an orchidectomy, and even in a localized setting or locally advanced setting, patient will do fine, is probably not the norm now. The people are seeing variable outcomes. People are landing up with multiple metastases. Their quality of life becomes miserable. So aim of robotic surgery is or prostate cancer surgery is not just one fold. It is not just cancer. It is a cancer outcome as well as functional outcome, which includes quality of life aspects as well, including urinary issues. So if all of us, I'm very sure all of us must have seen many patients with urosepsis in the terminal stages, hematuриas, ureteric obstructions leading to stents, urosepsis, succumbing to urosepsis and not cancer. So these are the sequelae which we get often in India, unlike Western countries. So
post surgery, how do you manage incontinence? I mean, robotic surgery has reduced the incontinence, but how do you manage, prevent, and treat?
Yes, so we preempt the patient actually to start with the Kegel exercises. They are no more called Kegel for at least prostate. It is scientifically, it is called pelvic floor muscle training, PMFT, and where we actually tell them that there are two types of exercises. I always give a handout to my patient preoperatively, which includes all the information on possible complications, possible outcomes, the way to manage the incontinence, steps they should be taking care of throughout the course, and a comparative bulletin between surgical arm, radiation arm, etc. So there are two types of pelvic exercises: fast twitch and slow twitch fibers, and they will be there is a wide literature available on reinforcing these. Obviously, during the surgery, like I said, bladder neck preservation is the key pillar for incontinence preservation, so which we do regularly for some cancers. For example, tomorrow's patient has a disease coming next to the bladder neck, so I am not going to preserve the bladder neck. I have already explained it to the patient that your incontinence will be little prolonged than expected, because the first priority is a cancer outcome. So patient has a high risk disease tomorrow on a catheter, this is coming until bladder neck. So it's like a mutual discussion for like 1 hour or so with the patient and the relatives preoperatively, until I sincerely embark on the strategy of thorough counseling preoperatively, giving the entire honest bracket to the patient, and ultimately the patient is going to decide about the treatment which he would want to obtain. It's like a platter therapy. You give everything to the patient, describe about everything in and out, and then the patient chooses what he would want to do, understanding the pros and cons and his acceptable level of complications.
So does the incontinence improve? Are there any drugs?
So there are no drugs. So like I said, preoperative Kegel exercises, intraoperative nerve spare, intraoperative bladder neck spare. These are the main things which are in control. Non-controllable things are disease status or the biology of the disease, age of the patient, level of continence, and obesity and diabetes. So all these factors are high risk factors. Elder the patient, higher the chance of incontinence. Younger the patient, better would be. Diabetic, obese will have little poor outcomes. But eventually, sir, I'll be honest, the numbers or the figures, if you ask me, we always quote these honest numbers in our counseling. I will never say to my patient that you will be continent immediately after catheter removal. It is a process. There is a reason for it, because we are shaving the prostate off the bladder neck. Your bladder neck becomes compromised, and hence the entire function will be taken care of by the striated external sphincter, and hence until the time it regains its function, there will be incontinence. So it happens for at least 6 weeks to 3 months. Majority individuals will fall into this interval. 5% will still be incontinent beyond 3 months, and 1% will be incontinent beyond 1 year as well. These are the exact numbers which I always tell it to all my patients. Few patients, a disclaimer here, few patients are still will get continence immediately after catheter removal. For example, I operated upon a medical practitioner from Thane. Actually, he is a 75 but extremely fit regular swimmer. So he had a good pelvic muscle, good pelvic floor. He was continent on catheter removal. He was leaking only for 1 or 2 days. After that, he stopped wearing pads and diapers. But obviously, that's not the thing which I do it on my routine counseling. I always tell that you have to be mentally prepared for 6 weeks to roughly 3 months.
So if there is a family of cancer, prostate cancer, like 2-3 generations, is there a role of having a radical prostatectomy done like a BRCA thing in breast?
No, sir, no, because like I said, the incidence, even if there is, firstly, the BRCA positivity in prostate cancer is a new thing. Nearly the incidence of BRCA positivity or the familial actual genetically associated cancers are only 8 to 10% cancers, firstly, out of which BRCA positivity again drops to 1 to 2%. So in general, less than 1% attribute. And even if he develops a prostate cancer, it is going to be picked up early because that patient will be vigilant on screening modalities because he has a strong family history. And in early stages, his risk of dying of prostate cancer will be exactly equal to the individual who doesn't have a family history. So prognosis based on the family doesn't change much. BRCA2 has a little adverse prognosis, but not to a very large extent. And again, what quick here, BRCA1, BRCA2 positivity testing in prostate cancer is very important, not just for his son, but for his daughter as well. Again, going to the breast and ovarian cancers, I have done it for 4 patients so far. All 4 had their daughter and the son as well. Why daughter? Because if you have a BRCA positivity in the patient of prostate cancer, and if it is positive, then I would encourage the daughter and the son to test their blood for genetic or the hereditary mutations as well. A son dying of prostate cancer because of hereditary nature is much lesser, but a daughter dying of breast or OV where the BRCA is implicated as well, BRCA1, 2 are implicated as well, is much higher. So a physiotherapist dad and a gynecologist dad I operated upon, I got the BRCA testing, and it was negative fortunately. Then obviously I didn't probe further for testing their son or daughter's sample, but patient sample was tested for BRCA1, 2. So daughter, if patient has a daughter, I'll be more alarmed or a threshold for getting the testing done is much lesser for me in a high risk status.
So manual radical prostatectomy, it is a dying art because of robotic surgery. What is your take on that?
So yes, sir. So open radical prostatectomy, I will never criticize anyone who is doing open surgeries to a very good extent. All my teachers have taught us that, and those people are doing good job in open or laparoscopy are doing excellent work. I will probably offer robotic approach in my hands because I prefer robot, to be honest, for my better functional outcomes over the open surgery for prostate. Any surgery done well should have good results for the patient. I will never criticize anything.
Should dutasteride be given in high PSA?
Yeah. So there was a trial called Reduce, and there was similar to dutasteride, another molecule called finasteride. There was another trial called Finast. So 2 trials, Reduce and Finast. These were the trials which told us about possible role of offering these agents to reduce the cancers. The clear outcomes were they reduce the risk of prostate cancer in a clinically non-significant cancer, meaning Gleason 6 cancers, but they do not prevent the outcomes or chance of carcinogenesis in clinically significant cancers, meaning Gleason 7 onwards cancer, which needs actual treatment. So they clearly demarcated that there is no role of dutasteride or finasteride in giving to the patient to reduce the chance of cancer. Again, with the dutasteride or finasteride, PSA slowly starts falling down and down. So for that individual who has background raised PSA, I would probably not give it, because the PSA is a reliable marker. I'm going to monitor that patient every yearly on PSA and probably subjecting him to the biopsy or the MRI if there is a PSA rise. So probably I'll not give that patient dutasteride or finasteride. So generally the policy which people follow is PSA not too high, and a patient is already ruled out of prostate cancer on 1 or 2 occasions, and a gland size is much bigger, say 90 cc or 100 cc, then they can be offered dutasteride. My practice, I generally do not go for it, to be honest.
Last question: any relation between prostate cancer and diet, non-vegetarian diet or anything like that?
Yeah. So no direct relation. There was a good paper, in fact, sir, in New England Journal of Medicine, one of the highest possible journals, which told us that there can be a role of saw palmetto berry. That it is one of the product which is not available in India. I don't know, to be honest, whether it is available in India, where they used it on a n number of people, and probably did mention that the risk reduces, but it is not a normal practice anymore. So there is no recommended diet for prostate cancer carcinogenesis prevention. But like I said, for every carcinogenesis, healthy diet, with antioxidants, fresh fruits, all these things are going to
without being said. Yes.
But no direct implications.
Thank you very much, Dr. Ashwin.
Thank you,
wonderful talking with you and wonderfully answered questions. Thank you so much.
Thank you, sir. Thank you for the opportunity.
Thank you,
I ask Dr. Usha Shah to take over.
Now the last speaker is Dr. Dipali Borade. And to introduce, Anil is there, Jitesh?
Yes, I'm there. I'm there.
Okay. Then I request Dr. Anil Lawad, our president-elect, to introduce the speaker. Over to Anil Lawad.
Yeah. Thank you, Dr. Usha Bhavi. Dr. Dipali Borade is a consultant radiation oncologist attached to Apollo Hospital, Navi Mumbai. She is diploma in radiation oncology from Pravara Institute of Medical Sciences, Loni, followed by DNB in radiotherapy at Jupiter Hospital, Thane. She has work experience with advanced radiation technologies for all solid and hematological malignancies. She has expertise in the brachytherapy of gynecological malignancies, head and neck cancers, and sarcoma. She has presented papers in various national and international conferences. Today, she'll be talking to us on brachytherapy, expert treatment with internal radiation therapy. Over to Dr. Dipali.
Thank you, sir, for such a nice introduction. I would like to thank you, IMA Mumbai, and Dr. Jitesh Mehta, sir, Dr. Girish Lad, sir, Usha ma'am, and Dr. Kajal ma'am for giving us the opportunity to present our work in such an interactive forum. After the imminent multi-specialty talks about the asthma, thyroid, breast, and urology, I would like to talk about the part of radiation therapy in cancer treatment. So we'll share the screen now. Yeah, so my screen is visible?
Yes, ma'am.
Okay.
Yes.
Okay, so we'll start from the what is radiation. Radiation is the emission and propagation of energy through the medium or space. So whenever we are treating using this high energy radiation for treating cancer cells, it delivers precisely measured dose of radiation to a precise volume, and thus increasing the chances of eradication of the tumor and improving the quality of life. So how it acts, as all we know, how the functioning of the cathode tubes. In cathode tubes, we use the electrons which are accelerated to the high potential medium, and it produces the X-rays. Similar mechanism is applied for the linear accelerator, which are the high-end machines for radiotherapy. So in this machine, generally the electrons are accelerated through high voltage medium, and then the electrons are hit one target, and then they produce the X-rays. And these high energy X-rays will be used for killing the tumor cells. How they kill the tumor cells is when they hit the cells, they damage their DNA, and thus either killing the cells or either reducing their reproduction capacity. Thus, after inhibiting their reproduction capacity, the cells get killed and absorbed by the body. In this mechanism, the normal cells are also killed with the these high energy X-rays, but normal cells have the capacity to regenerate. So within few weeks, these normal cells will regenerate, and patient will be recovered from all the side effects. So the evolution of radiation therapy took place from the cobalt era to the high energy proton therapy. But with the linear accelerator, the evolution is like from the box field technique. Like previously we used to treat with the rectangular fields or square fields. With that, the evolution is like today we are treating with fusing the functional scans like PSMA scan, PET scan, and on that functional scan, we can see the tumor area and we can deliver high dose to that particular region only. So from 2D, two-dimensional techniques to high-end IMRT and IGRT techniques we have evolved. So here you can see whenever we are giving rectangular field, we can involve the bladder, rectum in this case. But when we divide this field into multiple beamlets, we can shape around the tumor and can deliver higher dose to the tumor region. So brachytherapy is a type of radiation therapy. Radiation therapy can be given either external therapy or the brachytherapy. Whenever the radiation is given externally, the source is on the external side of the patient and it delivers dose through the body. It is called external therapy. And in brachytherapy, the source is placed inside the tumor or inside the soft tissue of the patient, and thus it delivers dose from inside to out. Then it is called brachytherapy. And the functioning of the brachytherapy is on the inverse square law. Whenever it travels the maximum distance, the dose will be fall down. So the dose will be delivered near the tumor, and there will be minimum dose or no dose to the surrounding normal structures. In this brachytherapy, we'll use the sealed sources, which are very small sources. They are attached on the wire, and that will put on the tumor or inside the soft tissues, and that will deliver the radiation in the geometric fashion. So thus it allows very high dose to the tumor and very minimal dose to the normal structure. If we go back into the history, how it is developed, as all we know, the French physicist Henri Becquerel accidentally discovered the radioactivity, and thus it started the era of radiation oncology. So this afterward, this discovery of radioactivity leads into the starting of radiation therapy as a brachytherapy, because they use this uranium as a contact therapy to treat the tumors. The first use of brachytherapy was done by the Pierre Curie, who showed that whenever you are inserting this radioactive material into the tumor, it causes shrinkage of the tumor. That's why it is also called Curie therapy or brachytherapy. And the early pioneers like Margaret Cleves, she used it for gynecological malignancies, showing the improved local control as well as survival with the use of this brachytherapy in the gynecological cancers. Afterwards, the brachytherapy is also used for other malignancies like prostate malignancies, breast malignancies. So it is very highly localized radiation therapy, which treat very small volume with high control rate. It spares the surrounding normal organs and tissues, and it's a very conformal therapy. The treatment time is shorter because nowadays we used to use the high dose rate therapy. So treatment will be finished within minutes. It has non-homogeneous dose distribution. So some part of the tumor will be hypoxic, some part will be necrotic, so that we can manage our dose according to the tumor area and we can give the non-homogeneous dose. But it's the disadvantages are like it is invasive procedure, needs expertise and experience and good instrument for delivering this brachytherapy treatment. It is quite time consuming, and that's why many centers will not have the brachytherapy machine, because many times the investment will be much higher rather than the treatment delivery. So very few centers in the India is having the brachytherapy machines for treatment delivery. So according to the NCI consensus guideline for gynecological cancers, the 5 randomized trials have shown that chemoradiation is preferred over the surgical treatment for locally advanced cervical cancers. And all these trials included the brachytherapy as a part of their treatment along with the external beam radiation therapy. Again, a recent publication from Tata Hospital that have shown that for locally advanced cervical cancers, chemoradiation is better than the chemotherapy followed by surgery in locally advanced cervical cancers. And brachytherapy was also the part of this trial. This is again one of the publication from Tata only, presented in JAMA Oncology in 2020. So it has shown that chemoradiation has improved survival over the radiotherapy alone. So for cervical cancer, generally we give radiation, concurrent chemotherapy followed by the brachytherapy, which definitely improves the survival. For endometrium cancers, according to NCCN guidelines as well, for locally advanced cancer, definitely the radiation therapy is the part of the treatment. But even for the early stage endometrium cancers, where the dilemma is whether to give adjuvant treatment or no, in that case also brachytherapy plays an important role. Whenever it is grade 2 or grade 3 endometrial cancers, early stage endometrial cancers, the brachytherapy will be added for the treatment. So according to the evidence-based data, according to the randomized control trials, these are the sites which are shown in blue colors. These are the proven sites in which brachytherapy is used, and the labeled in pink are the trials in which other retrospective studies are available. Because these are very rare sites for the tumor, and to do the randomized control trial is very difficult for these sites. So many retrospective studies shown benefit of brachytherapy in these patients. So for prostate cancer, for breast cancer, for head and neck cancer, it is already proven technique which is showing benefit in the randomized control trials. So according to NCCN guidelines, the major indications for brachytherapy are cervical cancers, in which if the patient underwent surgery, we can add it as an adjuvant therapy when the high risk features are there, or either a radical treatment with the chemoradiation followed by brachytherapy. For endometrium cancer, it will add an adjuvant treatment. For early stage, it will be only vaginal brachytherapy. And for locally advanced cancers, it will be external therapy followed by brachytherapy. For prostate cancers, which are like early prostate cancers, in which the concept of organ preservation therapy is there, in which we can use brachytherapy or external therapy. And sometimes in locally advanced prostate cancer, which need external therapy, in that case, we'll add brachytherapy as a boost. For breast cancer, whenever the early breast cancer patient comes, we can deliver the brachytherapy during intraoperative time, so that we can insert the catheters during surgery only. After removal of the tumor, we can identify the tumor bed and will put the catheters there, and the patient will be treated within 5 days. So her whole treatment, the surgery followed by the radiation, will be over within 5 to 6 days. So why for few cancers it is required to add brachytherapy as a boost? If you see the tolerance doses of these structures like cervix cancer, uterus cancers, these are 200 to 300 gray. The vaginal mucosa is 160 to 200 gray. For bowel, small bowel, urinary bladder, the tolerance is much less, like 40 to 50 gray or 55 to 60 gray. So we can't deliver this 200 gray through externally, because these are the organ at risk: small bowel, urinary bladder, rectum. So in this case, we have to add brachytherapy as a boost so that we can achieve this much dose to the target region. So part of the radiation will be added externally, and the boost will be added with the brachytherapy. So there are different types of brachytherapy. According to the method of source loading, they are called preloading, afterloading, manual afterloading, or remote afterloading. In previous era, whenever the radioactive sources have to be inserted manually, it was a preloading manual system. But nowadays, due to advancement in the computers and technologies, we can do the afterloading. Means we can sit at the console and we can give order to the machine so that the source will travel through the connector and it will go to the body of the patient. So there will be less exposure to the treating physician as well as the technologist. At Apollo, we are having remote afterloading system of the brachytherapy. So according to the application, it is like intracavitary brachytherapy. Whenever we are putting the radioactive source into the cavity, it is called intracavitary. Again, interstitial brachytherapy is the one in which we are putting the source inside the soft tissue of the patient. It is called interstitial. Intraluminal brachytherapy, whenever the source goes into the lumen of the patient, it is called intraluminal. Like for esophageal cancers, we can directly put the source into the esophagus. So it is intraluminal brachytherapy. According to dose rate, also the brachytherapy is divided into low dose rate, high dose rate, and pulse dose rate brachytherapy. So whenever the dose rate is most, which was the common treatment previously, but now nowadays it is absolutely abundant. Now we are using high dose rate radiotherapy only. In low dose rate, the dose rate was around 0.4 to 2 gray per hour, so that the treatment used to last for 22 hours, 24 hours. In high dose rate, the dose rate is more than 12 gray per hour. So that if we want to deliver a 7 gray or 6 gray to the patient, the treatment will be delivered within few minutes. And in pulse dose rate brachytherapy, the brachytherapy is delivered in pulses. After few hours gap, again the next pulse will be delivered, that is called pulse dot rate brachytherapy, but nowadays it is not practiced. So for gynecological malignancies, the steps involved for image guided brachytherapy is, in OT procedure, we'll put the applicator under anesthesia, either under spinal anesthesia or general anesthesia. We'll put the applicator. Then after recovery of the patient, we'll take patient to the imaging. We'll do the CT scan there so that we can see the position of the applicator, position of the bladder, position of the rectum. Then we'll reconstruct the applicator. We'll mark the bladder and rectum area and our target area. After reconstruction, the dose will be decided, what dose we want, like the uterus should get, the cervix should get, or the upper vagina should get. The dose will be finalized with the 3D dose planning, and dose will be delivered through these connectors. So these are different brachytherapy applicators which are available for the treatment. Generally, we use the modified Fletcher suit applicator so that it will have one tandem area which will go to the uterine canal, and two ovoid structures which will sit near the fornices, and thus it will cover the area, like it can give radiation to the uterus as well as the cervical part as well as the upper vagina. Nowadays, the new applicator has come, which is having ring applicator, so that we have to, whenever we have to increase the dose around the cervix or around the vault area, we'll use the ring applicator. So this is the dose distribution of the brachytherapy. We generally reconstruct the bladder and the rectum on the CT and the applicator. And this is the dose distribution. So in this, the uterus is quite good covered, plus the cervical part and the upper vagina part is getting the maximum dose. And beyond that, the dose is very minimal. So this is the new applicator in which it will have some needles. Whenever there is high parametrial disease, we want to give boost to that parametrial region also. In that case, we'll put extra needles around this tandem. So it will give coverage to the parametrial region. So for vaginal brachytherapy also, whenever the patient comes after surgery, we want to give dose to the vault area and the upper part of the vagina. In that case, we will use the vaginal cylinders so that they will provide the radiation to that area. So according to the size of the patient's vagina or vault region, we'll choose the applicator from small to highest applicator. And this is the dose distribution around that applicator. So here you can see the red line is the highest dose, that is the 100% dose. Inside it is the 1 to 120% dose, and inside it is 150% dose. And outside it is like only 20% dose. So it will give maximum dose around the target area and very minimal dose around the soft tissue. So this is another technique to give boost to the vaginal part. This is called interstitial brachytherapy or Mupita application, in which we'll put the applicator under anesthesia and with the epidural analgesia for 2 or 3 days. And the needles were placed in the vaginal part and the parametrial region. So here you can see the dose distribution around the target area. So the bladder will get very minimal dose or no dose, and rectum is also spared in this very conformal technique. So these are few applicators used for vault and vaginal brachytherapy. Whenever there is vulval disease, we either put the applicator, or if the tumor is like superficially, then we can put the freehand needles, and through that needles, we'll put the catheters inside that region and give radiation through these tubes. So again, the prostate brachytherapy. For prostate also, whenever it is early stage prostate cancer, it can be treated with the brachytherapy as well. It can be either permanent brachytherapy or temporary brachytherapy. In temporary brachytherapy, again, we can use the same template which we have used for vault or vaginal brachytherapy, and we can deliver a precise dose around the prostate cancer. And the total treatment will be over within 5 days. For breast brachytherapy, intra-brachytherapy will be done. After removing the tumor, we'll put the catheters around the tumor bed, and after 2 days, we'll give the radiation through these tubes. So it can be done either in the 2 planes or 3 planes. The connector will be attached to these tubes, and the radiation source will come from this machine to the patient area. It will treat this area and it will go back to the same case. So this is an example of soft tissue sarcoma. So it was on the abdominal wall, which was removed after surgery, and the catheters were placed inside the tumor bed, and afterwards the radiation was delivered within 5 days. This is again a soft tissue sarcoma for like rhabdomyosarcoma in the pediatric population. So whenever we are treating pediatric population, the brachytherapy has its own importance, because if we give radiation through the external source, the developing part or developing bone will get the dose, and it will affect his growth afterwards. So it is very important to give very localized treatment for the pediatric population. So in this case, whenever the tumor is removed, the catheters will be placed around the tumor, and the treatment will cover only this part, not the radiation will not go beyond this part. So the bone will be saved. This is another rare case. This was a rare deposit of leiomyosarcoma. The patient was treated for leiomyosarcoma of uterus, but she has single neck deposit. The PET scan was not showing disease anywhere. She was started on palliative chemotherapy, but was progressing on chemotherapy without any visceral metastasis. So we, in our tumor board, we decided to go ahead with the surgery followed by the radiation. Because she was a short neck patient, it was very difficult to give radiation through the external technique, because then the food pipe, the other side of the neck will get the radiation. That's why we went ahead and we decided to give treatment with the brachytherapy. After removing of this deposit, we put the catheters and we reconstructed the catheters, and the dose distribution was like this. Only this part was irradiated. Recently she came for follow-up. You can see here there was no any skin reaction. The scar is also very fine, and she was not having any neck deformity as well. Few patients with the head and neck cancers. For head and neck cancers, like early lip cancers, early tongue cancers can be treated with radical brachytherapy. This is a case of radical brachytherapy. For the lip cancer, it was an early stage N0 disease in which we put the catheters and we delivered the radiation. This patient is controlled with the radiotherapy only. Then this is the base of tongue cancers, in which we can't deliver the full dose with the external therapy. In that case, we generally give boost to this area. So this base of tongue lesion was treated with the external therapy followed by the brachytherapy. So to conclude, these are the small iridium sources which can robotically driven through the multiple channels, and which we can put it into the patient tissues, and we can deliver the treatment. These are the higher dose delivered in quicker time. So whenever we use the image guided adaptive brachytherapy, it has included both the local control rate as well as the it has reduced the normal tissue toxicity. But it will need the expertise, experience, and good equipment as well to deliver proper brachytherapy. Thank you.
Thank you, Dr. Borade. It was a very nice session.
Thank you, ma'am.
Any question, Jitesh bhai?
Yes, madam, there are no questions as such.
No, I want to ask one question.
Yeah, bolo.
So when you are deciding that you are going to do radiation and then brachytherapy, so how do you divide the dose? Like how much of to be given through brachytherapy and how much to give through the other radiation?
Sir, there are like standard tolerance doses. Whenever we feel the bladder and rectal toxicity will be more with the external therapy, we divide the dose. Generally, it is around 75 gray is the tolerance for bladder, rectum, and 85 for the bladder. Whenever we are giving dose, we consider at least the bladder should be spared in external therapy. We'll give 50 gray through the externally, and then remaining dose will be added with the brachytherapy.
So it is percentage wise or it is intensity wise?
Sir, it will be percentage wise.
Okay.
Any cost effect? Any differences of the cost? Internal and external?
Yes, ma'am, because the internal radiation therapy will involve the anesthetics, the OT charges, plus the equipment cost. So the internal radiation therapy is a bit costly than the external therapy.
So are the rods reusable or they are disposable?
They are reusable, sir.
They are reusable.
Yes, yes.
And do they cause any peripheral radiation when you use the rods and the needle?
No, sir, because the source will go inside at the center of that rods or that equipment, and it will deliver dose from inside to out. So at the surface of the applicator, there will be very minimal dose.
Okay, so it will not spread outside.
No, sir.
Thank you very much.
Thank you, sir.
Thank you, Dr. Dipali Borade. It was a very nice session. Now I request my assistant secretary, IMA CGP, Dr. Kajal Ahuja, to give a vote of thanks.
Okay, good afternoon all. I would like to thank our speakers for today's webinar, Dr. Rajesh Swarnakar, Dr. Prashant Chahat, Dr. Agam Bora, Dr. Anil D. Cruz, Dr. Sandeep Bipte, Dr. Ashwin Tamhankar, Dr. Dipali Borade. I also thank our knowledge partners for the day, AstraZeneca and Apollo Hospital. I thank Mr. Dipen Mehta, Mr. Chirag, Mr. Piyush Kale, and Ms. Vaishali Tanpure from DigiShield, who have given us the platform for this webinar and handled all technical details at the same time. Thanks to Dr. Anil Awad, Dr. Usha Shah for conducting this webinar smoothly and efficiently. A big thank you to Dr. Kiran Desai for being MMC observer for today's session. Last but not the least, I thank you all the delegates for participating in this webinar in large numbers and making it a grand success. Thank you very much.
Thank you, IMA CGP, for a wonderful program, and thank you very much.